making it here today. We have some of our participants already joining us on the Zoom over there, and we want to thank you for honoring our invitation. We shall be starting once we have everyone settled. So we shall give it another about 5 minutes, and we should be able to commence the event. Thank you so much.
Medical access is Medical Access is a not-for-profit organization that pioneered the introduction of antiretrovirals in Uganda in 1998 at the peak of the HIV/AIDS epidemic, in collaboration with the government of Uganda, Centers for Disease Control and Prevention, and participating pharmaceutical companies. Since then, Medical Access has reached more than 2 million patients with diagnostic tests and life-saving medicines for a range of infectious and chronic diseases. And we remain committed to delivering cost-effective, reliable, and sustainable healthcare supply chain management solutions to ensure that all patients have access to the highest quality medicines when and where they need them. As a full-service ISO 9001-2008 certified organization, we specialize in the procurement, warehousing, and distribution of pharmaceutical products and healthcare commodities. How can we help? The best way to find out is by following the journey of one of the products managed by Medical Access. After 2 decades of working in close partnership with governments, international funding agencies, local implementing partners, healthcare providers, and patients, Medical Access has a keen understanding of the intricacies and challenges of effective supply chain management in Africa. Before the product arrives, we work closely with regulatory authorities to make it possible to import new products efficiently into the country. We also work with high-quality international and local suppliers to a broad range of reliable products and deploy a range of proprietary tools to accurately quantify product needs to avoid stockouts and loss of resources through expiry. Once the product arrives, it is securely stored in one of the Medical Access managed state-of-the-art warehouses. Our NDA-licensed modern warehouses located in Kampala, Uganda, have more than 20,855 cubic meters of storage space and 116 cubic meters of 24-hour backed-up cold chain storage capacity. Want to know where your product is and stock status? Our proprietary SAP MIRS system and control tower provides end-to-end real-time data visibility at all levels of the supply chain. Now the product is on the move. As your eyes and ears on the ground, we reach a wide network of customers across East Africa, including more than 10,000 hospitals, pharmacies, clinics, supermarkets, wholesalers, and retailers. From packaging, labeling, loading and offloading, transportation, cross-docking, transloading, reverse logistics, and real-time surveillance, and last-mile delivery, we've got you covered. We've covered more than 1.5 million accident-free kilometers across the country since 1998. Deliveries are made using well-maintained, fully equipped, and cold chain-capable vehicle fleet that is tracked using web-based. Patients receive the product in a secure, timely, and efficient manner. Where possible, through our Center for Health System Strengthening, we also seek to identify opportunities to build supply chain capacity. 2,000 health workers from more than 200 health facilities have been mentored by Medical Access, and several in-house forecasting and tracking tools have been put in place to improve drug logistics in the field. Together, our goal is to enhance human health by closing the gap between the demand and availability of high-quality, reliable healthcare products in Africa. To learn more about Medical Access, visit medicalaccess.co.ug.
founded 20 years ago, 1998 to be specific. We were founded as part of a collaboration of UNAIDS Drug Access Initiative between WHO, UNAIDS, the pharmaceutical companies, as well as the Ministry of Health in Uganda. We are part of the Global Drug Access Initiative at a time that was founded when they had just discovered that antiretroviral therapy, or highly reactive therapy as it was referred to at the time, was capable of improving the quality of life of people living with HIV/AIDS. That's how we were founded. Through our Center for Health System Strengthening, we've also been able to build the capacity. I think for some of you who've been able to visit the warehouse, you heard from the team that does the work, especially in the training and equipping the healthcare workers with skills in good housing practices, in forecasting. And then we have also had the opportunity to also share the same best practices through provision of technical assistance internationally as well. I wish to acknowledge and thank the active collaboration and cooperation of a number of our implementing partners, including Baylor College of Medicine, Child AIDS Fund of Uganda, Infectious Disease Institute, Makerere University School of Medicine Program, formerly MJAP, Uganda Virus Research Institute, Maldime Uganda, Rakai Health Sciences, Reach Out Mbuya, the AIDS Support Organization, TASO, the Uganda Episcopal Conference, Uganda Prostate Medical Bureau, AMREF, RTI, WaterAid, Elizabeth Grazier, Intra Health. Your engagement has been very instrumental in guiding and providing insight to enable us achieve the successes that we have shared with you during the tour. The health facilities and practitioners have been the cornerstone of our success, and we would like to recognize them in a special way. And I would like to request the audience to give them a big clap. I would also like to most profoundly thank the government and people of America. I don't know, it's very difficult to express our gratitude, but we are very grateful.
And then joined WHO, and I had the privilege to be part of the small team that set up UNAIDS with Peter Piot. At that time, we had a major breakthrough, which was antiretrovirals, that really changed people's life, the people with HIV. And it wasn't an easy answer, it was not obvious. People were saying, yeah, no, there are a lot of side effects.
Medical Access specializes in pharmaceutical procurement and supply chain management across Africa. It has implemented an integrated enterprise resource planning system as a strategy to leverage technology to improve supply chain management. Bi-monthly orders and reports are submitted by the health facilities through a web-based ordering and reporting system directly to the central warehouse. Orders are received, reviewed, and consolidated into the Medical Access Supply Chain Information System, after which a consolidated order fulfillment list is generated and transited to SAP. The orders are processed in SAP and pick and packs are generated by facility. The pick and packs are transited to the warehouse for bulk picking using PDA devices with barcode reading capabilities. During this process, there is a 24-hour surveillance system to ensure security of the commodities which are being picked and packed. The warehouse is equipped with material handling systems to enable warehouse personnel to replenish and retrieve commodities. Warehouse staff are clad in personal protective wear, and temperature, as well as humidity, is monitored throughout the warehouse. Before goods are staged on the dispatch area, warehouse personnel conduct primary verifications to confirm items, quantities, as well as batch numbers. Goods are then transferred to the dispatch area for bulk breaking. Each facility
problem of HIV infection in Uganda started where early in the 80s, but kept growing so that by the early 90s, it was a very big problem in the country. The people were very scared. They were afraid to be associated with it. They didn't want to talk about it. They went underground, went to traditional healers, and even many doctors and other healthcare workers them much.
At that particular time, there were probably something like 10 or 12 million HIV positive people in Africa, of which, if I can recall, there was only something like 500 patients were receiving antiretroviral drugs. Appointed by UNAIDS to be their first negotiator with the multinational pharmaceutical industry to secure access to antiretroviral drugs in Africa. When we started to involve the pharmaceutical industry, the questions they were asking was all about security of supply.
So we thank you so much. Throughout this morning, we've curated a program with a number of speakers and colleagues that will share their experiences and stories through the implementation of the project. And in case you have any questions or need any assistance, I'll be moving around. I'll be available to support on that. So once again, we welcome you to this forum. And at this point, I'll welcome the chair, Mr. Andrew Semgenyi, to take over and start the event. Thank you.
Thank you very much, Claire. The CDC Country Director, the Commissioner, Department of Pharmaceuticals and Natural Medicines, the Executive Directors of our partners, distinguished guests, colleagues in the health and supply chain fraternity, hospital directors and managers online, ladies and gentlemen, good morning. Thank you for joining us today. Thank you for joining us today to mark the end of the Health Supply Chain Improvement Project. In a special way, I would like to recognize the presence of our colleagues we've worked with from the private health facilities across the country. We especially thank you for being with us on this day. I'm Andrew Semgenyi, and I'm the principal investigator for the HSIP project. I'll also be the chair of the session. As we gather here, I would like to take a moment to reflect on the journey we've embarked on together that essentially started in September 2011 when medical access was granted the first cooperative agreement. But more specifically in April 2017 when the HSIP project started, and in the period where we've witnessed the incredible efforts put forth by each and every one of you to streamline and develop the supply chain for PEPFAR and HIV in general in Uganda. Today is a significant milestone for medical access as we bring to a close a project that has demanded perseverance, dedication, and collaboration from each one of us. From its inception until now, we've encountered challenges, we've overcome obstacles, and achieved great results together. As the principal investigator of the HSIP project, I would like to express my gratitude to each team member for their hard work, commitment, and steadfast dedication throughout the last 12 years that we've implemented the CDC project. Your unwavering determination and professionalism have been truly inspiring to Ugandans and the rest and everyone. It is important to acknowledge the incredible progress we've made together. We set out with clear objectives, and against all odds, we've managed to achieve each and every one of them. Your innovative ideas, strategic planning, and diligent execution have been the driving force behind our success as medical access. Throughout this project, we faced numerous complexities, tight deadlines, and unforeseen circumstances, yet we've overcome these challenges with resilience, adaptability, and teamwork. Majorly was the global COVID-19 pandemic that disrupted global logistics, let alone the ability for us to deliver commodities to our clients. Our ability to think creatively adapt to changing circumstances, and collaborate with one another has been commendable, and we thank you very much. Today we stand here not only as a successful team, but also as individuals that have grown both personally and professionally. This project has provided many of us an opportunity for growth, development, and the chance to acquire new skills. It's been a true privilege to witness many colleagues embracing the opportunities and continuously striving for excellence. As we conclude this project, I urge all of us to take a moment to honor and celebrate the achievements. Individually, we are all capable, but together we've accomplished something extraordinary. I'm incredibly proud of each and every one of you. Moving forward, let us take the valuable lessons we've learned from this project and carry them with us into our future endeavors. Let us continue to embrace challenges, think outside the box, and collaborate with the same level of dedication and passion that has brought us here today. In closing, I would like to extend our gratitude to PEPFAR through CDC and the Department of HHS, in general stakeholders, and all those who have supported us throughout this project. Your trust, support, and guidance have played an integral role in our success. As we part ways with this project, we continue to reminisce on the humble contribution we've made to supply chain management in Uganda, and the knowledge you've gained and shared, which could be positive in contributing to the future structure of health commodity procurement, warehousing, and delivery of health commodities for HIV as we look towards the final end of the HIV epidemic in Uganda. We at Medical Access look forward to contributing further in the future as we transform health care delivery in the country. On the agenda today, we've lined up a few presentations that will be made, and as per agenda, we'll be having a presentation from Medical Access to highlight the project scope, the achievements, and the lessons we've learned. And under the project, we've also been able to undertake 3 evaluations related to process, outcome, and economic evaluations. We have in our midst consultants who undertook the evaluations, and we shall provide them an opportunity to present their results. So that will be followed by a closeout session that will be presided over by our chief guest, and that's the Commissioner of the Department of Pharmaceuticals and Natural Medicines at the Ministry of Health, and the CDC Country Director. So first on our agenda today, we'll be hearing from Dr. Rashid Setala, who is the Senior Director of Senior Director of Programs at Medical Access, and he'll be taking us through the lessons we've learned under the project, under the theme Leveraging Technology and Partnerships to Implement HSIP. So I'll ask members to note any questions or areas of clarification that you may have at the end of this session, and we look forward to hearing from Dr. Rashid. So I'd like to hand over to Dr. Rashid for the presentation. Thank you very much.
Commissioner, Minister of Health, Dr. Christina Mwangi, who is representing the Country Director, distinguished guests, ladies and gentlemen. It's my pleasure to present a snippet of what we have achieved or what we have gone through in this project as we come to close this project. In my presentation, we'll be looking at introducing the program, its background, how it was implemented, what were the achievements, and what are the ideas. But in doing so, I'll be demonstrating some of the areas where we have showed innovation and ingenuity to ease the implementation of this project. I'd also like to warmly welcome the online audience, facilities that we have worked with for over the last 12 years, for the wonderful contribution and cooperation they have showed us. The project title was has been Procurement, Logistics Management, Warehousing and Distribution of HIV and TB-related commodities to the private not-for-profit facilities under CDC-supported regions in Uganda. This project started in 2017, and it was supposed to support 300 facilities in 62 districts in 6 regions, with a total budget of $232 million. And we baptized this project as the Health Supply Chain Improvement Project. Project purpose was to strengthen the health supply chain by ensuring uninterrupted supply of HIV and TB commodities and building sustainable supply chain management practices at CDC-supported PNFP facilities, regions, and laboratories in Uganda. The biggest lesson we know about HIV management is that supplies are critical to the implementation of care and treatment, as well as prevention services. And over the time, we have noticed that interruption in supplies has significant impact on outcomes of patients that we tend to serve and the population. So in this project, there were like 4 outcomes or areas of focus or strategies. The first was to strengthen the national coordination of product selection, specification, forecasting, quantification, and supply planning. The most important thing has been over the last 12 years dealing with supply chain in Uganda at a national level has been try and eliminate duplications. So this project was established to ensure that there is coordination between all parties, that is PEPFAR, Global Fund, the government of Uganda, through the Ministry of Health. So that was the first strategy. The second strategy was strengthening procurement management practices. And the opportunity was for a local organization to establish international standards of procurement so that we can be trusted as a nation to manage funding for commodity procurement. And the third strategy was to support a nationally integrated inventory and distribution management system. This meant that we had to ensure that there is total visibility of products we have in stock, and this visibility is coordinated at a central level, and it would be able to inform the needs of the country as a whole, and not necessarily as a project or as an institution. But at the same time, making sure that the distribution management practices are as per the guidelines of the Ministry of Health, and that is delivery to site or last mile delivery, and ensuring that there is coordination of that system. That includes the ability to manage ordering, to manage commodity resupply and delivery. And the fourth strategy was to ensure that there is a strong supply chain management system at the end user level, focusing mainly on data and ensuring that we utilize data to make decisions. So those were the objectives that were set out for in general for this project. This project was awarded to Medical Access as the prime recipient, and we had 2 sub-recipients. One was Palladium who was a subrecipient responsible for developing IT systems, and then ACASIS, or Axios Foundation, out of Cleveland, in Ohio. These organizations were helping us to develop systems that we were able to utilize in implementation of the project. We would like to recognize, most significantly, all your partners for the support that you have provided us in terms of stakeholders. This project was being managed together with a couple of stakeholders. And as you know, in project management, when there are several stakeholders, you've got to coordinate several instructions, several guidelines, several requirements at the same time. But we'd like to thank all of you for the support that you provided in ensuring that you guide and support us to implement these objectives. So, how did we approach this project? So we said that the goal was to strengthen the national system, but we had to do that through procurement, warehousing, and distributing HIV commodities. So we identified, through a log frame, we identified a number of activities that we wanted to implement under each strategy to ensure that we have an efficient supply chain. Remember that for products to be at the facility, for programs to run, there are a number of factors that we look at. There are a number of aspects that happen before that. And so some of the things that we found to be very critical was the balancing between the specifications that are required by the programs, as well as the guidelines from the ministry and PEPFAR and US FDA and US government federal requirements. We had to make sure that we balance the board so that there are no instructions coming from one that impact on the other. A case in point are the ART transitions, where we would find that the government is recommending the utilization of TLE, for example, and then PEPFAR is recommending the utilization of TLD, and we have to make sure that we balance all those requirements and specifications. We looked at procurement, and one of the biggest goals that has been we are proud of is supplier relationship management, identifying suppliers who are compliant with the requirements at a national level as well as at a federal level, including local suppliers. But most importantly, making sure that we procure commodities in an efficient manner, in a transparent manner, and at the best price possible. There are a number of things that you would think about that can actually make procurement go wrong, but some of the activities, including timeliness of delivery, quality management, and delivery of commodities according to plan. The third strategy that we implemented was, like I said, the aspect of a nationally integrated inventory and distribution management system, and that required us to ensure that we provide appropriate warehousing and delivery systems, as we shall see. But then the fourth strategy was, how do we ensure that our services are managed utilizing real data? So some of the anchor concepts for this project included cost efficiency, ensuring that there is cost efficiency across procurement, warehousing, and transportation. The next concept was speed and agility, managing commodities delivery as soon as they are required, and that also included emergency procurements or emergency delivery of commodities to facilities. We had an incident of a flood that happened in Kasese, I think in 2020, at the peak of COVID, where one of our facilities, rain went through the hospital and specifically through the store that was accommodating the products. And so there was a big challenge nationally for us to ensure that patients do not miss treatment, and we were able to deliver commodities in record time, and patients' treatment days were not changed. So some of those were some the ideas that came out of this: minimizing stockouts and expiries, as you know, making sure that there is fit-for-purpose storage so that commodities are stored in adequate amounts at the facility level to ensure there are no stockouts, but also expiries not being mixed with viable stock, as we found several practices in some facilities. Quality assurance was very important, as well as data visibility and information management as one of the cores. So at the beginning, we did a baseline, and some of the aspects that we remember very well were critical, included issues related to lack of supply plans. There are very few facilities that were able to provide a supply plan. In procurement, vendor pre-qualification, and patient, many of our practices in the country did not require us to pre-qualify vendors and making sure that we are procuring from correct people. No systems to evaluate vendors. Pharmacies and stores management, 90% of the facilities did not have any up-to-date standard operating procedures in place. Facilities with stable grid power, specialized inventory software to manage commodities as the times require, and of course, security features. So there were issues related to logistics information systems. 100% of the facilities utilized manual systems to manage inventory, with a few that had concurrent electronic systems. And then, of course, quality assurance, pharmacovigilance SOPs. For many of our systems, pharmacovigilance was not in place as a critical aspect. So we over the time, we managed over 574 products under 22 health commodity categories. We were able to develop standard specifications utilizing both CDC and Ministry of Health guidelines. Our forecasting and quantification was either based on epidemiological data or real-time data for utilization. We were able to support the national system in developing a supply plan for HIV commodities. We also adapted with other global models in the environment, and also we were able to quantify and upscale a number of new commodities, including ready-to-use therapeutic foods, a number of new test kits, as well as TB commodities, among other achievements, as you read in the report. And then, of course, procurement management. There are a number of things that we think were key in our approach, but at the same time as in success of this project. But most important of which was the number of suppliers we managed. 383 suppliers were providing commodities to the project, and amongst which there were local suppliers, which for us was a very proud moment, because whereas we were procuring from local entities, we were able to achieve pricing that was competitive globally. We were able to negotiate with suppliers and achieve savings as a result of that. And we also had a lot of emphasis on quality assurance and continuous monitoring to ensure that at all times we do not fall in terms of process, in terms of timelines, in terms of prices, and in terms of quality. On inventory management and distribution, some of the areas we focused on was to ensure that we have a state-of-the-art farmer-grade warehousing system that can be able to accommodate inventory for all facilities for a period of 6 months. It's important because the facilities that hold stock can be a great hindrance to continuous availability of commodities. But on the other hand, it is not every store that stores health commodities. There are a lot of areas that need to be improved, that need to be set up for you to store health commodities, as you all know. So that was one of those areas we focused on in inventory management. We also proud product traceability technology, where we were able to implement the GS1, the barcoding, the electronic proof of delivery systems that would be able to link products from source to the end. And then, of course, the inventory management system, we're able to provide information that would help us to manage commodities efficiently, utilizing a pool system. We ensured that all facilities would receive commodities up to 4 months. We conducted last mile delivery, and we also supported the public sector with commodities worth close to $17 million to achieve that nationally integrated inventory management objective. When it comes to strengthening supply chain management systems and data utilization, each and every facility we were assigned, we did a baseline study, we developed a roadmap for capacity building, we developed and utilized models for mentorship and strengthening systems. We supported the facilities utilizing the SPARS model, which was the national system for health system strengthening, and the SPARS model was adapted as a mobile app so that it can easily be utilized by facility heads, can be utilized by regional or district management supervisors. It can be utilized by our staff as a tool to manage and monitor support performance. We were able to implement RX solution, WOWs, tools, and other systems that were generated by government. So this was a very important objective of the project, to create an electronic logistics management information system. We developed real-time stock visibility. We developed a model pharmacy concept where every region had pharmacies that had achieved a certain grade of performance, and there were the model pharmacies within that region for others to emulate practices. We developed the e-learning system for sustainability and capacity building, and we'd like to encourage that tool to continue to be used because it helps to reduce the burden of training and capacity building. So these are some of the achievements. I may not go through all of them, but over time, we noticed that the project had experienced changes. For example, in 2017, we started with 216 health facilities supported. In 2018, we raised to 254. In 2019, we had 295 plus 33 for PrEP, which was the peak. And then after that, we started seeing changes. So in 2020, 50 facilities that were private for profit were removed. In 2021, 182 facilities were transitioned. So 52 health facilities were transitioned, and eventually in 2022, 182 facilities were transitioned, until we reached the end when every facility was transitioned to support in 2023. We would like to thank all the health facilities for the support they provided, and also the diligence in taking on the directions we had provided. What are some of the lessons we have learned? That when you are implementing supply chain data integration, you need to develop the culture of utilizing data. So manager in supply chain should consider that the culture of data quality and data ownership is very critical. For somebody to know that when I utilize commodities, I have to record, and this data then results into the need, the identification of need. I can be able to utilize that data, and it is my own. It's not for the Ministry of Health. It's not for the health authorities in my organization. And then, of course, the other lesson is procurement is a process, so there is need to have a continuous assessment of pipeline and stock status in order to inform procurement decisions. And I know that at the Ministry of Health, we've had opportunities to review data, but the most important thing is we have been reviewing it in a reported form, but not in a proactive form. So as we move forward, it is important that at all times we look at the dashboard. How much stock do we have? Because things change and decisions can be easily taken, but they have a great impact in procurement. So having an analysis of stock status and pipeline is very critical, and meetings to discuss this. It is important to note that at times there are elements of saying that yes, we have the data and we have the report, but that is not what is important. Engaging the partners to ensure that you know exactly what's happening is critical. And then at the facility level, for members also online, at the facility level, we also found that one of the best practices is routine physical counts. Yes, you might have the information in the system, but it's very important to establish at least a monthly physical count. That helps to enhance transparency, but also to ensure that you can rely on the data you have in the system. Price benchmarking and negotiations are a great best practice. Maximization of value for money is very important. This has been one of our greatest achievements, to ensure that when we are procuring commodities as an entity, we do not allow to be sold at a high price, irrespective of the quantity you are supplying. So having a relationship with the suppliers and making sure that negotiations happen is very critical. The other best practice is phased introduction of supply chain management technology. I think as in any IT system, introduction of IT systems is a process. But the idea is when you're going to introduce technology, you've got to know that there is a learning curve. The other element that was the best practice was utilizing supply chain technical team to provide physical support. Training of staff on stock management and inventory control is not enough. People need to be demonstrated to what exactly needs to be done and how. This practical engagement is something that will eventually improve the whole system. We have also learned commodity loss prevention is a key strategy that requires a number of areas of focus, because it is not true that commodity loss can only happen in one or two areas. It can happen at many areas. And so the focus of commodity loss should be at different points, as you'll see. And then, of course, consolidation of commodity budgets was a key observation, and that I think has continued to be one aspect that I see that the system, PEPFAR, and the ministry is taking on. So very briefly, on the element of the PNFP sector HIV program, the 95, 95, 95, these are some of the actual results. We supported safe male circumcision, we supported PrEP, we supported HIV testing, self-testing, syphilis duo, EID, as well as research testing for diagnosis. We supported treatment, close to 1.5 million person years of treatment, and equivalent of 25% of the national total on ART. And then, of course, we also supported viral load testing through the supply of viral load test kits. In terms of facility level improvement, we said we had a couple of models that we used, the mentoring and technical health system strengthening, plus e-learning were health interventions. But in addition to that, there was health system strengthening that included infrastructure enhancement and electronic systems. We supported a number of facilities with shelving, with medicine cabinets, and many other amenities, including temperature control systems and thermohygrometers. We supported stores with fire extinguishers, fire lockers, and many other amenities to support management of commodities. And then, of course, we had both physical and electronic testing. In cost saving, these are some of the benefits that over the years, the cost of treatment of a patient on ART has continued to decline, and this has been as a direct result of our negotiations with suppliers. I know that now we are looking at about $50 per patient per year, but this has been, we have been at par with global entities at ensuring that the pricing continues to decrease. Visualization and data visibility and automation technology was one of the greatest elements of improving supply chain practices. What we achieved was to make sure that every facility, first of all, has an electronic system. But in addition to having an electronic system, we created what we call an integrated facility data management system that would link that electronic system to the central warehouse, ERP, and we were able to visualize that through the control tower. And I know that this concept has now been adopted at a national level, and we are glad to have had that thought leadership in ensuring that whereas, yes, we can rely on the teams to do the work, but we need to even go another step to ensure that we automate that system. And then, of course, at Medical Access, we developed what we called the SAP-MIP, or the Logistics One database or system that would provide us supply chain information linking facilities and the central warehouse, and that had a couple of components that have all been implemented successfully, resulting in several advantages in supply chain management, which we're proud of. We talked about the mobile SPAs. This is a supervision tool that is used as an electronic data assessment for any supervisor. The benefits is rapid information transmission. So once a supervisor goes to a facility, when they key in their observations, they're automatically sent to this to the center. This eliminates errors or associated with manual data entry into the system. It also helps in the supervisor's supervisor to manage the visits, and because there is a geolocation stamp. Of course, the other element that was in the system is instant performance scores computation, so the facility would know how they're performing today based, compared to when they performed the last time, and that would help them to develop plans for change immediately. And then, of course, this can be achieved, adopted at the ministry level or any other level. And of course, it helps to offer accountability for time spent. The other element that we think has been a big success in the project has been the development of the e-learning platform. The supply chain e-learning platform was developed with 11 courses, and these are available. These are the critical courses for any supply chain program. The platform has been handed over to the Ministry of Health. The ministry is also developing an integrated e-learning system, and these components have been very, according to what we've been informed, have been very resourceful in ensuring that we strengthen that system. And this course, this e-learning platform is available, but as the ministry adopts it, then we may have to use the one at the ministry. But this is still available for partners to use and partners to adopt in ensuring system strengthening going forward. We also talked about the supply chain control tower and the 360 degrees data visibility as one of our objective 4. Real-time data visibility is very important for decision making and also making sure that somebody can be able to tell, to make decisions on time, bearing in mind the knowledge and information that the system can provide. It also supports to improve security of commodities, because you can be able to visualize commodities as they are moving. For example, we had a system that would track the delivered vehicles, and the system can be able to tell when the vehicle stops, when the vehicle doors are opened, and timestamps, and also geolocate those vehicles and relate that to where the vehicle has actually been sent. So several developments on 360 data visibility have gone on in supply chain management for health commodities, but we are glad to have been part of that journey. So there are many other aspects that we're proud of. For example, we were pioneers in a number of products being introduced for HIV care and treatment, including recency testing. We were pioneered in bringing the recency tests here, the HIV self-test, the syphilis duo. We were part of the initial suppliers of TB, IPT, as well as other TB commodities in the project, when it was realized that now it's important to go strong on HIV, advanced HIV disease. In terms of distribution, we have been extremely grateful and lucky that we have distributed close to $240 million of stock across the country in the project, more than 6 million miles traveled to more than 300 facilities on a bi-monthly basis during that period, and there was no loss of a single product along the distribution chain. And 98% the products were delivered on time. So we are proud of that milestone as well in support of improving access. I'd like to just look at very briefly some of the other best practices in risk management for supply chain. We have talked about all of them, I think. The quality assurance process, the stock management and monitoring process is another area where focus needs to be put in managing risk. The digitization, especially the GS1 and what we call commodity traceability, is very critical. We call it COVID-19 protective measures, but this is essentially a big disruptor. So risk management in situations where there are big disruptions in supply chain globally, risk mitigation strategies are very critical, as well as commodity loss prevention. Like to say that quality assurance, like I said, starts from product selection, but goes all the way to pharmacovigilance and quality assurance processes. It's important that when you're looking at quality, that it is not something that you look at in terms of NDA registration, but ideally across the chain. We also look at the commodity loss as a process where there are a couple of areas where you need to be able to improve commodity loss prevention risk. And this mitigates risk of commodity loss, including, like I said, having a visibility and an analytic network. You need to have an end-to-end visibility. When products are about to come to country, you need to be able to have an idea where the products are and be able to notify and follow them. When the products are in transit, they need to be insured. You need to ensure that there is stock verification and reconciliation at receipt, as well as health facilities, ordering and reporting system to be quality assured. A lot of times you find that orders placed in the system are not necessarily out of, I wouldn't say out of intent, but maybe out of error, may be wrong, and that may result in oversupply of commodities, and these commodities would then become lost as a result of misallocation, and not necessarily any bad practice, but just a matter of making sure that every order that goes into ours or any other system has been quality assured is very, very critical as one of the aspects. Just to mention a few of the strategies that we have used to mitigate risk. In terms of sustainability of the implemented solutions, we recommend strengthening capability and capacity of the regional and local supply sources, making sure that local suppliers as well as regional suppliers have the necessary quality to provide the commodities for the country going forward is very critical. We think that maintaining collaboration with medical access as stakeholders in supply chain will foster cross-ideation. That is also one of our recommendations for sustainability, that we think that we can continue to provide ideas on how to improve supply chain. Then the third one is continuous improvement. We have been involved with continuous improvement practices in the project for the last 12 years. And like I said, as we moved on, we kept reviewing our systems, looking at the risks, looking at any eventualities and learning from them very quickly and continuously improving. So I would like to encourage the supply chain management stakeholders to adopt the culture of continuous improvement. And then, of course, strong risk management practices is very critical, and ensuring continuous optimization of inventory levels as programs transition. So as you see now, there are changes that happen every day and going to happen, and they're going to continue happening in this journey, but how do we continuously change and optimize? So in terms of the summary of the key takeaways, some of the achievements: all products procured were in line in national treatment guidelines. We had one national supply plan. We provided computers for the electronic ELMIS to all facilities that lacked them. We provided on-time delivery to 80% of our shipments, and more than 85% of the commodities were below the international benchmark pricing. We were able to deliver commodities close to $240 million to more than 250 beneficiary health facilities in a day as the average order delivery time. And of course, we attained zero stockouts of all key commodities. 95% of the facilities received a computer and with an installation of the RX solution. 100% were WAOS reporting, and we supported a couple of personnel training, especially in electronic logistics management information systems. So effective communication and collaboration is critical, to aligning goals and responsibilities, flexibility to ways and approaches yield alternatives that support innovation, collaboration, and leveraging a learning culture will help the health supply chain system, continuous feedback mechanisms and stakeholder engagement, and establishment of mechanisms for continuous improvement. We would like to say that we're setting up a resource library, our website, articles we published, as well as the social media as plans of sharing the information and the skills we have garnered over time. Lastly, I'd like to thank our partners, all of you, for supporting us across this project, and we look forward to continuous partnership to ensure that we achieve our goals. I thank you.
Thank you very much, Dr. Rashid, for that exhaustive presentation on the objectives and impact of the HISIP project. I think some of the key highlights I picked up is the fact that we managed to get savings that were used to procure and reach more patients, given the limited resources that we continue to face in implementing these projects. Ensuring zero stockouts at health facilities, that's something very key to note, and then the data visibility and utilization. So thank you very much, Dr. Rashid. At this point, we'd like to invite one or two questions or points of clarification from the audience. Any question? Was it very clear? Do we have anyone online that has a question for Dr. Rashid?
No, I think at this point we just have congratulatory messages. So no questions.
Okay. So thank you again, Dr. Rashid. I would like to hand over to Claire to guide us through the next session.
All right. Thank you so much, ladies and gentlemen. We have a full room now. We also have over 40 people online joining us over the Zoom call and the live stream. So we thank you and welcome you once again. We appreciate Dr. Rashid for the insightful presentation. And I think at this stage, we are due for a well-deserved break. Just recharge a little bit before we continue with the program. We have some refreshments back here. Just a chance for you to get up and stretch your legs, continue to network, and we should be able to resume with our program within 30 minutes. We are on time in accordance with our program. So we'll give this 30 minutes. We'll also encourage our online participants to get up and stretch a bit, and then we should be able to resume on time. So we shall be back at 10:40 exactly to resume. Thank you.
Medical Access is a not-for-profit organization that pioneered antiretroviral propaganda in 1998 at the peak of the HIV/AIDS epidemic. in collaboration with the government of Uganda, Centers for Disease Control and Prevention, and participating pharmaceutical companies. Since then, Medical Access has reached Medical Access is a not-for-profit organization that pioneered the introduction of antiretrovirals in Uganda in 1998 at the peak of the HIV/AIDS epidemic. In collaboration with the government of Uganda, Centers for Disease Control and Prevention, Medical Access is a not-for-profit organization that pioneered the introduction of antiretrovirals in Uganda in 1998 at the peak of the HIV/AIDS epidemic. In collaboration with the government of Uganda, Centers for Disease Control and Prevention, and participating pharmaceutical companies. Since then, Medical Access has reached more than 2 million patients with diagnostic tests and life-saving medicines for a range of infectious and chronic diseases. And we remain committed to delivering cost-effective, reliable, and sustainable healthcare supply chain management solutions to ensure that all patients have access to the highest quality medicines when and where they need them. As a full-service ISO 9001-2008 certified organization, we specialize in the procurement, warehousing, and distribution of pharmaceutical products and healthcare commodities. How can we help? The best way to find out is by following the journey of one of the products managed by Medical Access. After 2 decades of working in close partnership with governments, international funding agencies, local implementing partners, healthcare providers, and patients, Medical Access has a keen understanding of the intricacies and challenges of effective supply chain management in Africa. Before the product arrives, we work closely with regulatory authorities to make it possible to import new products efficiently into the country. We also work with high-quality international and local suppliers to a broad range of reliable products and deploy a range of proprietary tools to accurately quantify product needs to avoid stockouts and loss of resources through expiry. Once the product arrives, it is securely stored in one of the Medical Access managed state-of-the-art warehouses. Our NDA-licensed modern warehouses located in Kampala, Uganda have more than 20,855 cubic meters of storage space and 116 cubic meters of 24-hour backed-up cold chain storage capacity. Want to know where your product is and stock status? Our proprietary SAP MIRS system and control tower provides end-to-end real-time data visibility at all levels of the supply chain. Now the product is on the move.
During this process, there is a 24-hour surveillance system to ensure security of the commodities which are being picked and packed. The warehouse is equipped with material handling systems to enable warehouse personnel to replenish and retrieve commodities. Warehouse staff are clad in personal protective wear, and temperature, as well as humidity, is monitored throughout the warehouse. Before goods are staged on the dispatch area, warehouse personnel conduct primary verifications to confirm items, quantities, as well as batch numbers. Goods are then transferred to the dispatch area for bulk breaking. Each facility order is then verified, packed, and labeled. Goods are transferred to the preloading area for inspection. The outbound goods are then loaded into appropriate vehicles for delivery to the health facilities. The fleet management system monitors the geospatial location, speed, fuel consumption, as well as the distance of the vehicles, amongst other key performance indicators, through a web-based application accessible on mobile devices as well as computers. Health facility personnel can also track the status of their order using our web-based order tracking system, accessible on mobile devices as well as computers. On arrival at the health facility, goods are offloaded and verified by nominated health facility personnel. Nominated health facility personnel electronically sign on PDA devices to confirm proof of delivery of the order before goods are put away into facility stores. The real-time automated proof of delivery notification is then received at the central warehouse in our integrated SAP MIRP system, marking the end of the order and fulfillment process. In order to avoid stockouts, the central warehouse supply chain control tower is able to visualize and track the real-time stock status at health facility level through the linkage to the health facility electronic logistics management information system. Using customized business intelligence software, we are able to track real-time key supply chain performance indicators which inform timely decisions to ensure continued efficiency of the supply chain system. Once the commodities have been received at the health facility, our Center for Health System Strengthening team comes in to build capacity of the health workers in managing the products using a customized support supervision tool designed into an application which is administered during the visit. Through the Medical Access Supply Chain Institute, we are also able to train individuals in supply chain management using customized curricula and courses tailored to address the knowledge gaps of the students both in the classroom as well as in a virtual environment. Our e-learning online program provides a cost-effective and suitable environment for individuals to be able to access crucial training material in a self-paced manner, ensuring continual skills development. As a result of this 360-degree data visibility from the health facility to the central warehouse, we are proud to ensure efficiency, accountability, commodity traceability, as well as last-mile delivery.
The problem of HIV infection in Uganda started early in the 80s, but kept growing so that by the early 90s it was a very big problem in the country. The people were very scared. They were afraid to be associated with it. They didn't want to talk about it. They went underground, went to traditional healers, and even many doctors and other health workers couldn't help them much.
At that particular time, there were probably something like 10 or 12 million HIV positive people in Africa, of which, if I can recall, there was only something like 500 patients were receiving antiretroviral drugs. I was appointed by UNAIDS to be their first negotiator with the multinational pharmaceutical industry to secure access to antiretroviral drugs in Africa. When we started to involve the pharmaceutical industry, the questions they were asking was all about security of supply, security of distribution for their drugs, insurance that the patients get the drugs of high quality on time. We had to put together kind of a one-stop shop, I'll put it that way, where there would be a world-class procurement, supply chain, management activity.
The
The pilot project known as DAI, Drug Access Initiative, started as a small project without even a proper office. So I would say that we were sharing an office, we called it the corridor office, and we were all cramped in there, the supply side, the public health side, and the secretary, and CDC that was dealing with data, were all sharing more or less one office within the UNAIDS office. So Wedi, who was handling it, was very determined that it has to work.
Our first car was donated to us by Glaxo Wellcome, at a time a very old Nissan Primera that eventually they sold to us at $1. I was my own secretary, I was my own accountant, I was the general manager, I was a driver, I would go to the office to bank, I would pick the drugs from the airport and drive them to the container. And I would deliver them to JCRC or to Mbuya Military Hospital. I was hired at a time when the pharmaceutical companies had just discovered antiretroviral therapy. So I saw great opportunity for the organization and medical access to make a difference in the lives of people living with HIV.
When the UNAIDS Drug Access Initiative was announced, there was some hope in the country because at least we saw that few drugs were going to be able to come to Uganda under the Drug Access Initiative at a lower price. And then also were able to induce few changes in the Ministry of Health situation to see whether we could be able to put some of these drugs in a few paying hospitals. And at the same time, the Drug Access Initiative was able to negotiate for lower prices.
At the end of 2003, there was an announcement that there would be an initiative to get access to free medicines through PEPFAR, funded by the US government. On the 19th of February 2004, we received that letter that stated that we had access to money now to start patients on antiretroviral drugs for free. Within 6 months, all the patients that used to be lying down on small pillows and mattresses in the waiting room, they were all seated up every time they came for review. So it was like people who had died had resurrected and now they were seated in the reception area of the facility.
In 2006 is when I started talking to my patients in this clinic, in this hospital here in Miami. When they were not, because of stigma, they were not swallowing their drugs properly. Some of them were hiding. I somehow sort of started bearing myself, telling them, look, I'm swallowing these drugs myself. I'm on ARVs. Sometimes I had the habit of swallowing the drugs in front of the patients to show them that I was swallowing the same drugs. So actually, as far as fighting stigma is concerned, this program helped a lot because AIDS was looked at as a death sentence. When there's somebody who was like me, who was very sick with AIDS in 2000, now I'm okay.
Yes, Maria Street, how are you? I'm trying to follow up again. You indicated that you have a global scarcity of Zerit 30. We placed our orders in time, we forecasted in time, but there have been these delays, so we are a little bit concerned. Yes? Yes, but no, it cannot be, because if you push the orders up to April, then we will have run out of supplies. If you can give us 50%, we shall really appreciate.
Karamoja region has a very mobile group of patients who daily are faced with the challenge of, do I stay on ARVs or do I take care of my cattle, which is my basic means of survival? So most of the times they move looking for water and pasture for their animals. So being on life-saving ARVs becomes a second option or alternative. But you want those patients, or as many as possible, on HIV drugs for the rest of their lives. And also you want those who are on HIV drugs to maintain that resistance does not develop. What we did, because these are regions that have rainy seasons or wet seasons that spell for 5 to 6 months, which normally cut off transportation to them, we were faced with having to make our forecasting systems for these particular facilities a bit flexible. So instead of quantifying for them for 2 to 4 months, we had to stretch it as far as possible, like 6 months, so that for those that can be available during the 6 months of the wet season, they have sufficient supplies.
Sometimes we face challenges on our routes to the facilities. You find when the roads are flooded, the flying stones from the top of the hills coming down forces us to be very early in the morning, even if we go long trip to reach the facility, but we always reach and deliver the drugs.
When we took on this project, we had about 39,000 patients. Gradually, this number grew until the current date, where we have about 288,000 patients. So along the way, the number of IPs increased from 3 IPs to 14 IPs. And the number of sites increased from 18 to 218 sites. So this increasing number meant that we had to increase our warehouse space. And we felt that at this point we needed to get a home of our own, where we could build a state-of-the-art warehouse with all the necessary amenities that are essential for warehousing pharmaceutical commodities. It features a lot of standard recommended WHO practices, 24-hour security surveillance systems, CCTV cameras. We have a cold chain system that has 116 cubic meters. This is very large compared to the needs of the program. The benefit of the barcoding system was to enable us efficiently receive, put away, and warehouse commodities in the shortest time possible. The barcode system also enables warehouse personnel to be able to trace commodities during stock count or during retrieval or replenishment of commodities. Facilities can electronically sign on our PDA machines, and then we receive the information real time.
And we shall be starting.
There should be visibility of what is happening at all points. MAO's immediate plans are to implement what we call a 360 degrees supply chain data visibility through a system now internationally known as VAN, Visibility Analytics Network. This implies that you should be able to see from the supplier to the client. We have established a system called SAP MIP that has the visibility of stocks that the suppliers are going to deliver through our e-procurement system. We have established systems to manage the inventory when it comes to our warehouses, and we are again implementing electronic inventory management systems at facilities in order that we can be able to assist facilities to manage this inventory. So we are linking or interconnecting these systems so that we can be able to create an intelligent network. The advantages are several, but include the biggest one of ensuring consistent availability of these products, of health commodities at the place where they are required.
We are privileged to enjoy the installation of an online ordering system. When we're sitting here, we're punching in stuff, Medical Access can see what we're doing, so they know what is running out. They'll prompt you, this looks like you're going to need this, which makes life so much easier for the staff. It gets real-time response to our needs. We receive commodities between 3 to 4 million USD every year from PEPFAR through Medical Access. I can tell you, if I ordered commodities at 9 a.m. today, by 2 p.m. I would have everything that I asked for. And it means our patients are sure that if they come to us and it's a commodity they need from Medical Access, we will have it.
Medical Access implements a custom-designed mentorship and technical health system strengthening model that addresses the unique challenges the health facilities that we support are facing. Through this approach, we have been able to train, mentor, and supervise health facilities for them to improve their commodity management practices.
Medical Access has been instrumental in supporting us with capacity building, and as a result of that, we've never had any stockouts because we know how to forecast and we know how to order for medicines and maintain the number of quantities that we need. Because of their love for clients, we've been able to improve our services, and we are achieving the 90-90-90 UNAIDS goal because of the support and the partnership.
I want to say together with Mao, with you, because it's not just Mao, it's the partnership that's represented in this room today. We have made tremendous progress, and I look forward to us stopping this HIV epidemic, treating this disease. We have had assessment after assessment where we have looked at the price and the reliability of the systems that Mao has delivered, and they have always exceeded our expectations and beat global giants.
At the beginning of the year, we solicit for proposals of how we can support the communities in which we serve. Under the Restoring Hope initiative, which was initiated in 2009, we usually get quite a number of proposals. When we get these proposals, we sit as a team and do a thorough analysis and see where we think our contribution will have a great impact. If PEPFAR can come in and support fellow Ugandans, we also feel that even us as Ugandans, this is one way we can give back to society. This is one way we can make a contribution. So we have supported programs ranging from refurbishment of pharmaceutical warehouse, supporting orphanage homes.
They have also joined us every year to commemorate Patient Solidarity Day, to raise awareness on the critical role of patients, families, and community on how patients can get more involved, empowered, and engaged to improve the healthcare outcomes. And indeed, this interaction has provided an opportunity for Medical Access to interact and understand the needs of patients, and also being able to design appropriate solutions.
Tuli mu home care nga abalina akawuka ndi positive. Twali mu 2016 nga tutandika ekibiina kino nga tetulina ddagala. Abantu baali beekweka nga tebasobola kuvaayo. Ne tukola omulimu gw'amaanyi nnyo okubajjayo. Twamala okubajjayo ne tubale tugenda ku saa 12 tuvaayo ssaawa emwezi ekiro naye nga tewali RVs. Abantu ne bafa paka lwe twasisinkana ba Medical Access. Okuva olwo Medical Access kasita yatuuka bannange tufuna eddagala lyaffe mu bujjufu. Medical Access tubaagala nnyo, mwebale nnyo, mwebalire ddala, mwongere amaanyi era naffe tujja kwongera okubuulira abantu ekirungi ekiri mu ddagala.
Quick Access was founded 20 years ago, 1998 to be specific. We were founded as part of a collaboration of UNAIDS Drug Access Initiative between WHO, UNAIDS, the pharmaceutical companies, as well as the Ministry of Health in Uganda. We are part of the Global Drug Access Initiative at a time that was founded when they had just discovered that antiretroviral therapy, or highly reactive therapy as it was referred to at the time, was capable of improving the quality of life of people living with HIV/AIDS. That's how we were founded. Through our Center for Health System Strengthening, we've also been able to build the capacity. I think for some of you who've been able to visit the warehouse, you heard from the team that does the work, especially in the training and equipping the healthcare workers with skills in good housing practices, in forecasting. And then we have also had the opportunity to also share the same best practices through provision of technical assistance internationally as well. I wish to acknowledge and thank the active collaboration and cooperation of a number of our implementing partners, including Baylor College of Medicine, Child AIDS Fund of Uganda, Infectious Disease Institute, Makerere University School of Medicine Program, formerly MJAP, Uganda Virus Research Institute, Maldime Uganda, Rakai Health Sciences, Reach Out Mbuya, the AIDS Support Organization, TASO, the Uganda Episcopal Conference, Uganda Prostate Medical Bureau, AMREF, RTI, WaterAid, Elizabeth Glazier, Intra Health. Your engagement has been
was born looking at a pilot in, it was 4 countries, Uganda was one of them, but also it was in Cote d'Ivoire, Chile and Vietnam. So when we came to Uganda, and we said one of the things that is important is to make sure that the patients have continuous supplies. And at that time, the national medical stores and the joint medical stores who
we want to keep time, so we shall resume. I believe we've all been able to get something, and we are refreshed and we've got energy to power through the next session. Right before we closed, we had a presentation from Dr. Rashid, and there was a burning contribution that we didn't get, so we'll start with that, and then I'll hand back to the chair to move to the next session. Thank you.
Good morning. I just felt it wouldn't be fair for Dr. Rashid to make the presentation and we don't say a few things. So just to first of all compliment, I think, the HSIP project. I think significant achievement, but also just to note, as a country, or rather the health supply chain sector, one of the key interests right now is is moving towards digital systems, and that, of course, is in line with the theme of today, and some of the significant innovations that Dr. Rashid alluded to, noting, of course, the couple of them, the ESPAS, the POD, IFDMIS, SAP, MIRP. Okay, pardon me with acronyms. So I think for me the question really, Dr. Rashid, is, and maybe also to the other colleagues in the room, Pito as well, is how do we now start making sure that our other activities, for example, in terms of warehousing and distribution, the procurement, the distribution activities, that they adopt some of these innovations. There are some TWGs, for example, right now for ELMIS that we have at the Ministry of Health, and it would be, I think, important that at the very least we provide platforms for where we're having these conversations, at least learning and picking up as much as we can, so that we don't have another activity restarting anew. So I think my question now really is that, considering the end of HSIP, will medical access remain available to Ministry of Health to support these conversations when they are called upon, without at no cost? Yeah, so that we are able to learn as much as possible, but also to ensure that the efforts that you had do not go to waste. Especially now as we're moving, for example, to GS1 and those kind of things. So that's, and then I think Pito can also supplement by how, as a partner, how the PEPFAR team is supporting those conversations. Over to you.
Henry, thank you very much for the question. And of course, part of that question is above my pay grade, but as an elder now, Mr. Morris, now I'm an elder as well. As an elder, of course, we are proud to continue to offer any advice based on our experience. Also, I'd like to state that yes, the project ends in 2 weeks' time officially, but gladly we also have another paper project we are running, and this project we are running as a procurement and supply chain. Sorry, a procurement service agent for USAID, for PEPFAR, for Uganda, private sector. So we, as individuals or as an entity, may not be actually closed as a result of the closure of this project. And so we are there, and we are working together, and I believe that we can provide the advice as limited, but like I said, I say that with caution because it's a little bit above my pay grade. But just to ensure that I assure you that for whatever we think has been useful, we have provided. Also, as an alumni of Medical Access, you must have also noticed that so many initiatives at the ministry level were ideated in Medical Access, and that makes us very proud. And so for us, I think if there is anything that you feel can add value to the supply chain management, and it's a tool that we had, I think we're proud to offer the assistance and advice. Thank you.
Thank you very much, Dr. Rashid. Will Pito say something?
Thank you, Henry. That was a very important point you raised in terms of transition and sustainability. Significant resources were put at the disposal of Medical Access to develop those innovations, and it's our hope that those innovations do not end with a project. There's collaboration that's required between the project during closeout and Ministry of Health, Department of Health Information, as well as Pharmacy Department. We realize that there may be some costs related to these transitions, and our leadership within CDC is reviewing the possibility of some of those activities being funded under existing mechanisms, for example, METS, which is the Monitoring and Evaluation Technical Assistance Support Project. But we're also cognizant of the fact that these funds have been put in the above site supply chain mechanism, SSCS. So we'll see how best to collaborate to ensure that these innovations are transferred to the Ministry of Health for sustainability. Over to you.
Thank you very much, Dr. Pito. So I'd like to say that for those of us who are attending online, please try and register. You can jot down your name and the organization so that we have a record of who attended the session. Other than that, we'll come back from that break. We hope that you took time to get to know your neighbor and stretch. We shouldn't live here without knowing each other's names as much as we can. Yeah, so as earlier stated, we undertook 3 evaluations during the implementation of the HSIP project, and that included the process evaluation, the outcome and economic evaluations. And seated with me at the front, we have 3 consultants that were hired to undertake these evaluations. So to make it right, we have Dr. Drake Rukundo, who will be taking us through the process evaluation. Then we also have Dr. Jesse Lukwago that undertook the outcome evaluation, and then Dr. Jesse Luwama that undertook the economic evaluation. So we'll be giving each of our panelists 15 minutes to take us through the presentation. We are trying to catch up on some of the time we lost at the beginning. Yeah, so the first presenter is Dr. Drake Rukundo, who undertook the evaluation, the process evaluation, and he has a PhD in institutional economics from the University of Cape Town, and we hope to learn a lot from him. So over to you, Dr. Drake.
The country representative, CDC, the commissioner from the Ministry of Health, the health supply chain fraternity, the private sector health facilities representatives that could be here, my fellow consultants, my wonderful participants, ladies and gentlemen. About 3 years ago, we got a call that was through a competitive process to see if there could be a consultant assess processes for the health supply chain system that supported this HSIP program. We responded to the call, and after being successful, we are selected to do the process evaluation. 3 years is not a short time. I could have forgotten some things. It was a very COVID intensive time. Luckily enough, I think we did not lose many people to the pandemic. I think I was told that there's only one of your drivers who got a case, who got sick, very sick. So God was faithful, and we survived the scourge and continue to implement and serve our people. The terms of reference were to assess processes. So I will say one thing immediately for the participants. Medical access, thank you very much, but has been a razzmatazz of systems. The number one point, they said when you go there, tell them you have really showered the country with so many systems. They called it a razzmatazz of systems. Some of them are easy to use, others complex. So the first point I'll make, can we make them easy to use, accessible, and can they integrate into already government existing systems? So I said before you even speak, that should be number one. How, to what extent are these systems going to strengthen the DHA MIS2? That will be the highest utility from this process. Wonderful work, wonderful technologies, some installed, some in the process, some at 3/4 level, some finished and even pre-tested and rolled out, but they say here in the street language, "Muba to take speed." You've taken some of these people at terrible high speed. Some of them are not IT savvy, as maybe some of you are. So, medical access, slow down a bit. Slow down a bit. They are too beautiful and some of them too complex. The second was to really see the chain. So now, in chain process evaluations, we see the process as follows. Number one is that you plan. Number one is that you plan. Number two is that then after your planning, you procure using internationally tested systems. Number three is that you procure, you safeguard. You make sure that what you have procured is not lost. Is safeguarded, is safe. Then number three is that you now deliver. You now deliver. And this is where I now meet Ministry of Health. Some of the roads are horrible. Some of the times were heavy, rainy, people were struck. Even if you have the best truck in you, you have the best truck for medical access. Some of the roads were what? Then some people struggled with just internet access. No? He's been mentioning you are online, you are web-based, you're on the system, but some of them just struggled with just barely internet access, connectivity. Then electricity outages, isn't it? Electricity outages. These are some of them are really small clinics. They have to put up, when the electricity is out, they have put up the generator. And sometimes there's a gap between when the power has gone off and when the generator has gone on. So some of those little things. Then it actually matters in the process evaluations who is actually at the health facility. What type of human capacity is at that very health facility? Because as an institutional economist, I know Uganda, all these institutions exist, but who are the human beings? Who are the human beings inside these systems? Are they responsive? Are they incentivized? Are they motivated? Do they know how to go online, download, send out? Have they been trained? And this is where now all the tying is. And now when they have received, another process is, can they report that this was Wednesday? This is Friday, the 15th of September. This is what I have received. This data is put in the system. Ladies and gentlemen, data is as useful as only when it is used. Data is only as useful as only when it is used. And then they report back. Even if you have wows, now can you get these feedbacks coming? Because in the first time, we did, people were just on phone calls. I think, hey, your health facility, we have not seen you. Can you please? Because the person has not received the email. The person has not responded to your email. Now the last result is phone call, isn't it? Hey, how can you please send us? That responsiveness. And then the last one, which I liked that you mentioned, was on now data management for future planning and future progression. So we couldn't go to these health facilities. We were in the middle of the lockdown, so we sent out an online survey monkey using the Kobo Collect. So we used the Kobo Collect, we sent out the questionnaire to all the 157 health facilities. But because we had wanted to try to see physically some of them, we went to 25, And I want to thank TASO, which furnished us with the IRB and the data clearance. Then we also had some key informant interviews. Some of you spoke to me on the Zoom meeting. So let's begin with the first aspect. Now, using this diagram, we have something that I want to interest the government in. It is called the National Level Coordination for Quantification and Supply Planning Process. The project is over, but now I know in the exit strategy and sustainability strategy, this is now something you can grab by the two horns. It is not only medical access that is on this chart. It's joint medical stores. It is national medical stores. I've seen other stakeholders, Catholic Bureau, the Protestant Medical Bureau. We have so many other actors in this process. The more we get on board, the better, because we are also planning and implementing systems around HIV and AIDS support. And then we begin to think together now on a national level on where are the gaps, where can we strengthen our planning, who sits at these meetings, what are the takeaways from this planning process, how ready are stakeholders engaging, where does Uganda lag behind in this fight? Of course, we got so many medals. The president got so many medals on fighting HIV and AIDS, using the ABC. So ABC, we added D, isn't it? So it was abstinence. Abstinence, I think, Ugandans on abstinence. Ugandans on abstinence. My friend Grace, my friend Grace might be strong on that. Being faithful. Ugandans on being faithful. Question marks. Condom use. You have had the data from condom use. It has decelerated. Those of you who saw the report, now D is ours. And actually, when I was doing the interview, someone says actually AAD. So it is access, adherence, and then you check. You've been accessing and adhering, but now you check. Has that reduced your viral load? And then we see the gap in this process. Responsiveness. And then one of your commissioners in the midst was saying, okay, you have been giving the drugs, but now what is patient-to-patient response and reaction to this treatment? Some of that information is helpful for us in the process issue. Then when a consensus is arrived, then we can say, thank you, medical access, you've done your well on the supply chain management. Thank you, joint medical stores, but there's a gap here. Then each one gets a place to fill their gaps and their capacities. So thank you for participating in this process. But you can see the box is private, not for profit. But we still have others that need to be reached as well. On procurement, you really did well to do procurement review meetings. I think this was the process that really strengthened your work. Very few organizations do procurement review meetings to this grade. Because the procurement standards are known, they are global. You've been procuring from people who are already on the pre-qualified list. I think in the report you had about 178, from which you selected 67. They're already on the international competitive list. And the procurement is to ensure that you get the best. To me, that is the essence of procurement. You get cost efficiency, and you get the best. But also, even if I'm pre-qualified, I also need to go through a systems check. That's why they have the A listing of A+ up to D. So that you can't say I'm the best. You have to also go through the check. So I was very happy that even if you have high-class suppliers, you even had now a chance for some local suppliers. And I like that you emulated the point. chance for local suppliers also be part of this puzzle. It is in a way strengthening our capacities. Then you did what you had are the 5 key aspects in the process: on-time delivery, the quality of the commodity, the contract compliance, support, and the order fulfillment and price logo, which are all parts of 5 parts on the procurement list. And then you have these accredited labs, the ISO 1725 accredited labs, 5 in total, where you are also independently going to do some quality testing of your own. Because that is also important. You don't just say, oh, people are doing very well, they are pre-qualified, they are global standard, but you can also go back and check, do some quality check, and see what they have provided and supplying. Reported write or exchange damage was also just accidental, but also they had enough replenishment in any event, so it was still like up to 100%. I want to thank Medical Access, and I think we give a round of applause that we delivered 98.4% of all drugs to the people of Uganda. Congratulations to Medical Access. But now, there's something we saw we couldn't understand in the process evaluation. There are health facilities, private, not-for-profit, who are also getting support from outside Medical Access. So they double reported in some instances. So I don't know how your IT system, they were getting support also from other entities other than Medical Access. But when they go to their reporting logo, they seem to have reported everything they provided. So there's some data analytics that needs to attribute the supply they provided. So the data people should check it out, because other people got from other development partners, but you can't critically know what essentially was from you. That was a gap I think you can use. Then you had this data decision system. I am fine with systems, but they are always going to arrive at the same answer, isn't it? You can introduce a which system. I think there is WAOS or RX. You mentioned so of them. They are always going to deliver the right. They only one answer. I received the drugs. This was my patient list. This is the patients who received. To me, this is what is critical for you. This is what is critical for government. That the people who went to the drugs received them on time, and this is the report. So, thank you for the numerous systems, but let us focus our eyes on the outcome for the patient that we ultimately are the ones serving. But otherwise, SPAS, I think, was a model I really heavily recommend going forward, because it puts people in 3 ratings: gold, silver, and bronze, isn't it? The gold, silver, and bronze. So you could rank and say those who are in bronze next year, please push to silver. Those who are at silver, please push to gold, using the other rating score that you are given. So there'll be some internal pressure for people to improve their processes on their end. So not high, so 74.5% who reported that they are on the system. That means there's a chunk of people who need still capacity in this process. 87% who say that reporting online using house, that could improve. Those 13 points is still not very, very glorious. Would have expected at least 98%. 89.4% says that systems were really effective in ensuring time reporting and modeling. So 11 out of 100 still could get some support. Then I mentioned a bit already on this system, so I will conclude in my 15 minutes as follows. The Ugandans are not only going to private not-for-profit, they're also going for government facilities. They're also going to other private clinics for profit. Who will serve these people? It is us, it is government. So my prayer, members of the conference, is that what these innovations and systems have meant, because this is the theme of today, leveraging technology, isn't it? Flow this beautiful work to government and let the government absorb, appreciate, and mainstream these wonderful technologies in the other for-profit and government institutions. If it can be done by the smallest health centers in these local governments, in districts, it can be done for other health facilities. I have high hope in Ugandans' tenacity to do well if they are incentivized, given the technologies and given the resources. I have high confidence. Some of the nurses and some of the people we spoke to the health facilities, some of them are really done certificates that don't even have degrees. But they were incentivized, they were trained. Some of them had even never owned a laptop. But they were trained and they were incentivized and they could go on the laptop and then the nurse, one of the old nurses said, bring my mouse, my fingers can't, bring my mouse. And then she takes you through. I was quite warmed by what people can do. Some of them have never gotten a degree, but they were motivated. And then I think if you can do that in government, a lot of our people can be helped. Then help us to overcome these issues, internet, electricity, road network, strengthen the VHT system, create awareness and sensitization. But also when you do projects of this nature, and this is for development partners, you have an exit strategy. It was lacking. You have a sustainability strategy as part of the project design. So that you said it is closing in 2 weeks. There's at least a high level on what happens next. What happens next? Do we all go home? Do we cut the cake and have fireworks? Does this work get sustained? Let there be a report showing on what will happen next, and this can help us to sustain our efforts. And then I don't know whether it will be too laborsome, but the report mentioned that at least let us have a bi-monthly, biannual reporting. So you have quarters, you have quarter reporting, but let us also have a 6-month report on it, which is a accumulation of the first 2 quarters. Because then it will be easier for data analysis, and that can only be a high-level summary of the 2 quarters. Then the last one will be the annual report, which your M&E people can easily do. And it can also be like the one our friends at Uganda AIDS Commission have done, which is a high-level summary of what has happened in the first 2 quarters and what that lessons mean for the rest. It can be a small bulletin like I've seen in the brochures for the workshop. It could help the M&E and visibility for your program. Thank you very much for your impressive performance. You have done very well and have done yourselves, performed on all the indicators very clear in the report. O Uganda, may God uphold thee. We lay our future in thy hands.
Thank you very much, Dr. Drake, for that summary of the process evaluation. I think some of the key takeaways that we need to reflect on is a national integration of electronic systems, which I think he has tried to emphasize to ensure that there's continuity in the supply chain processes. So at this point, we'd like to welcome 1 or 2 questions or points of clarification to Dr. Drake from the audience. Okay. Do we have anything online? Yes.
Sorry, I feel guilty now that I'm asking. But I think the illustration on the quantification and procurement, quantification and supply chain process. Just an observation. I do not know where the information came from, but it does not quite represent the situation, because your question was on consensus. I think that's what you really try to emphasize on, gaining consensus. But as it stands right now, the Department of Pharmacy leads the quantification process, okay? And then that is then contributes towards the procurements that are supported by PEPFAR and the Global Fund, and which procurements then go to the respective warehouses. So I think you may need to revise that particular process, because there is already consensus at least, and we are trying to strive towards that.
Probably I can also give a comment in regard to the responses received from facilities on RX solution use. I saw that close to 75 facilities responded that RX solution was functional at their sites. But of course, this may not tally with what we see at the center, as the levels of data synchronization into the pharmaceutical information portal don't tally, because we currently stand at about less than 10%. And ideally, because in the report I saw that RX solution was rolled out in about, I think, 193 facilities or thereabout. So I would have expected a much higher number of reports trickling into the pharmaceutical information portal if the functionality was standing at about 75%. Thank you.
Thank you very much, Daniel. We'll give Dr. Drake a minute to respond to some of those questions and clarifications.
This was 3 years ago. This was 3 years ago. I mentioned it earlier. It was early days when I wrote the report, 3 years back. Yeah, if you could have even hit 100 by now, but I'm happy to see your latest. And if that's what you're saying, then again, very well done. And then on the issue of consensus, really it is people outside your fence. You're already doing very well on the structure you have, but what are the people who are outside your fence, who are in our sector? You can reach out to them. There are many other development partners in the private space, and consensus is a never-ending process. Even tomorrow an issue can come up, and then you take a look. Like under the COVID response, you remember the meetings were now like, how are we going to continue this COVID? How are we going to operate with some people able not to move when the lockdown, with staff not able to move at night because of the curfew? So there were issues will always arise that we need discussion and consensus about. So it's a process which will continue, that doesn't have a close. And that's why I was encouraging in the report Ministry of Health to cast the net wider and get other people to participate in these planning processes. It is good. If you talk to the social planning department at the National Planning Authority, the National Planning Authority would have loved to be part of some of these meetings. So, yeah. So because they plan for the whole country, and it would be good if NPA and some of these people could attend. So just an overview from an external evaluation. And if they are already there, then good.
Thank you. Thank you very much, Dr. Drake. So a round of applause to Dr. Drake. So our next presentation is on the outcome evaluation, and it will be given by Dr. John Lukwago, who was our supply chain management and pharmaceutical system strengthening consultant. Thank you.
Thank you once again. Thank you, Medical Access, for enabling us to come and contribute to this project and to the country. I want to acknowledge my colleague who has not been able to join us. Is Mr. Rauf Kawasi. Rauf Kawasi, briefly, I want to talk about him. He's a senior supply chain and procurement specialist. He brought on to this evaluation a wealth of experience from the Indo-Pacific region and the Middle East. The outcome evaluation, we will draw and base a lot on the process evaluation. We had a couple of questions that we are trying to get to the bottom of, to try to see if the outcomes that the project set out to achieve were indeed achieved. I also want to note that the presentation, a lot more has changed. This presentation was made for the time period, is it COP17 all through to COP19? I think you proceeded a little bit more. So, and I've heard already a couple of things so some of the results I may provide could have slightly, the figures could have changed, and most likely for the better. So, those were the evaluation questions. If I would give you time briefly to peruse through them. So there are quite a number of questions, but we grouped them into the 4 outcomes that the project set out to achieve. So the methods we used, we tried to find out what was the state of the supply of the pharmaceutical supply chain within the private sector by COP17, and try to follow it through up to COP19 and see what change or what contribution has the project made onto these outcomes. Because outcomes are really broad national outcomes, the project was only going to contribute to these outcomes. There were many other players that contributed to these outcomes, as you've seen in the diagram that has been shown in the previous presentation, and also other partners that you saw in the project in the presentation that was made earlier by Dr. Rashid. So these were all contributors to these outcomes. So the first outcome is ensuring improved national level coordination on project selection and quantification. Again, the evidence for this was that the HIS project contributed to all those supply plans, the PEPFAR, the Global Fund, and finally the Government of Uganda supply plan for all those 4 years. And in doing so, they used an array of activities, as probably has been described in the previous presentation. There was also an aspect at some stage where the project was able to fill in a gap that the country was facing, and the project was able to fill that gap of antiretrovirals into the public sector. Yeah. So, with regards that outcome, again, you struggle to recommend for medical access. You travel to recommend what they need to do going forward, because they've done a really tremendous job with regards procurement. The main driver within the procurement aspect was largely the use of the e-systems. They've used lots of e-systems that have enabled them to be able to negotiate. They've enabled them to have an overview of the market prices and be able to classify the offers that they receive, maybe above market value, below market value, and then be able to benchmark these prices and ultimately make a saving out of procurement. That is another key outcome that they received, and ultimately procurement as a medical access component is a very strong aspect that we noted, having been around to see other procurements happening in other countries like Swaziland and like Namibia. You realize that having a private sector entity in Maul that can, in the case of Maul, that can carry out procurements and distribute to a national program is really commendable. And you really want to also thank CDC for that foresight of being able to realize that there is local capacity that can deliver to such a level, especially with regards to procurement. All the other outcomes, as you've seen, are a bit country level, but this specific one of procurement is in-house within medical access, and that one was we had a chance to look at and review the task orders for many of the procurements that were done, and we are able to see a more deliberate effort that is made to ensure that the process is free, is fair, and provides value for money. These are really commendable aspects. And again, having been around, we were trying to understand why is it possible that this is possible in a private sector entity like Maul. And we only came to one conclusion, that probably it's that whole aspect from the dispatch clerk all through to being a private company, maybe to the shareholders, that is centered on delivering and is key on delivering value, because that's probably the only explanation why the procurement was so well done, and was able to provide value for money for the funders. So the third outcome, again, was to do with an integrated national inventory. Again, like I mentioned, the national inventory has many people that contribute to it. But again, regards what the project did, the warehouses, they were central level, they had 2 warehouses, and all these warehouses met the standards, the national standards. And in fact, these warehouses also went way above these standards, and were providing, for example, good security, ensuring that there is no leakage or privilege of goods along the route, like has been mentioned in the previous 2 presentations. So, and at the health facilities, again, the inventory system at the health facility and the storage at the various health facilities was also commendable. We visited up to 36 health facilities, and all these health facilities where we visited, we found that drugs were well kept. There was a secure place, temperatures well controlled. All the parameters were met. And again, is it because we are working in private not-for-profit hospitals? I don't know. I've also had a chance to look at public sector storage or store rooms where they keep the medicines, and you will agree with me, it's always a mess. So we found a well-organized set, however small they were or however large they were, depending on the facilities where we went. They were all well organized and kept safe. Stock cards for each drug by strength, everything was well done. So obviously all this was being done to ensure that the overall goal, that there is no interrupted supply in the delivery of products. So we try to have a look again, trying to see what has been the effect of the project on the actual provision of products. So we used WAUS data. WAUS is the web, you guys know WAUS, web-based ordering, something, okay? Now, here we are looking at a cohort of facilities. This project, the project had facilities in and facilities out. So, but what we did at this stage is we tried to get facilities that were in as of 2018. There was a reorganization that was done in 2018. So we got these facilities and looked at them before the project. So we had the benefit of WAUS and its data problems, but we made sure that all facilities we had reported. And you can see that when the project came on board, that is in 2018 after this new set of facilities, there was a reduction in facilities that we are reporting a zero stock out, okay? For a selected number of drugs. We selected a certain set of medicines or products that we tracked for that period. And so this is again evidence that actually the project did improve the supply of products. So this is the last outcome. Again, this has also been highlighted in the previous presentation. Basically, inventory systems at the health facilities, for all facilities that came on board, there was improving IT infrastructure, computers and modems. Then there was also they would install RX solution. Then again, they would go ahead much later as the project matured. They would try to link this RX solution with you call it HIS. There is a central warehouse, so that they could have visibility. Again, Doctor mentioned this earlier. So they would have visibility at all facilities and be able to see what's going on in real time. So really on the day of the visit, we didn't find any stockouts, and the stock was well monitored. Each product had a stock card that was up to date. When I say up to date, all aspects of it being up to date. The last time a stock count had been done was all noted on each product. The last time products had been received would also been noted down. The last time products had been issued, everything, all those aspects had been done. Now, that's an outcome of what the previous presentation mentioned. There had been also a deliberate effort of mentoring and coaching. These have been mentioned in the previous presentation: mentoring, coaching, and the e-training that you've had. So these were mentioned in the previous project, and these are the outcomes of what had been done. So again, this was again facilities at that time. You can see COP 18. That's when they had received new facilities into the cohort. So facilities had not got the necessary logins, and is it biostatisticians were helping out with trying to enter this project, but I understand by the end of the project now, by COP20, we are doing COP20, they're at 100%. Yeah. So, yes, this is the one where they were also at the time of the evaluation of the facilities that had RX solution installed. At the time of evaluation, that's how far they were with linking these facilities to the central warehouse. But I also understand that at this stage, they're at 100%. So, key recommendations. You know, now that the project has closed, I think whoever is going to be in charge of this is going to have to also make sure that there is a strict implementation of the various policies, if they do have them, but they would probably borrow a leaf from medical access. Then the use of the e-systems. Again, having been around, looking at various programs around the world, e-systems are the new thing, but again, they don't necessarily translate into what we found with medical access. And that goes back to the other point I mentioned, that there is something more than just having e-systems. E-system is good, you get it, it will definitely take you a mile, but again, there is a lot more if you are to get the results that we found in medical access. That was not an aspect for us to investigate. I mean, to be another study to see why, with adherence to policies, then also availability of e-systems, all projects don't really translate into what we found in medical access. So there are many other intricate things that medical access we are doing. They have this intelligence aspect. That's also a skill. I would call it a skill. Or again, it was not an aspect for me to investigate how they really do it. But this being able to have the intelligence to see our protocols changing, how do we adapt in time, you know? Because if you are to make savings like they made, the e-systems won't help you make these savings necessarily. But if you've not had the intelligence that protocols are changing, the guidelines are changing in time, so that you alert your suppliers, you know, you alert your suppliers, or you make all these adjustments in good time, so that you avoid then stock out. Then the other aspect again that again we noted again that whoever is going to be taking this forward also has to look at is supplier management, again, when we talk about the procurement aspect. Again, this is one area where at the time of the evaluation, the project was low on its targets with regards to supplier compliance, actually. But we also understood, or we know very well ourselves, the difficulty of managing suppliers. Some aspects can be well beyond the project. So those are key aspects. Then the warehouse. The warehouse again is another aspect that was state of the art. Again, we've been around, but what we found at the medical access warehouses was pretty impressive. You know, these were state of the house warehouses, but again, like I mentioned, having them also does not really translate in the results. Again, there should be something. For example, I'll mention one thing again that I found the best practice for whoever will be going forward with this project that medical access did. They ensured that all products coming into the country had a shelf life, still had a shelf life of up to about 75%. Is that correct? Yeah. So that's also a key aspect that whoever is going to go forward with this project has to ensure, because even if you have these state-of-the-art facilities and the shelf life is what it turns out to be, again, you. Then the other aspect, again, with regards to, here we are just trying to see, we are again trying to press to see what medical access could improve at the time. We are trying to really see, not that we found a mistake there or an error there in the warehouse, but we're just trying to see how they can maximize the layout of the warehouse. It's not that at the time of the visit, the layout in any way was hindering the movement in and out of products, but just for them to look within themselves and see how they can further maximize that space. So I understand all facilities now have user rights for WAUS reporting. And then the other aspect again is the training. We all know, myself having been in a private not-for-profit hospital years ago, 97, I was a medical superintendent in Nkozi Hospital. I don't know if Nkozi Hospital online, but I was there. And at the time, medicines, at the time then, the only product we had for HIV, I think, was Septrin. I think we only had Septrin, yes. And being in the private sector, for us at that time, we had to go to buy it from private pharmacies in Kampala. So having seen how things have really changed, to an extent that there is a project now, a private sector project at it as well, that has trained, because for us having been in the private sector, we didn't have a support training us in how to manage our products, our stores. In Nkozi Hospital, we had I think they still have a substantial size of store. Yes, we didn't have that capacity. We didn't have a project to come to help us. So all these are key outcomes. When I went there, I realized that the project had a proper impact. So medical access, thank you once again for the job well done, and for CDC as well. Me myself having been again in the private sector, in the private not-for-profit hospitals, again, please continue with us. I guess, I don't know if there's something following on in the private sector? Yes, so thank you so much.
Thank you very much, Dr. John Lukwago. For that, I think you did mention about the efficient procurement processes that you looked at medical access. And I think that's a very key highlight for the country, that we can actually continue to leverage some of these procurement systems to ensure that there's continued availability of commodities to the patients. So without giving Henry the mic, we're going to come later. Is there anyone else that may have a question for Dr. John? After that, we come to Henry. Yes. Yes, Grace.
Yeah. Thanks so much, Dr. John. You mentioned that one of your findings was that the e-systems did not directly translate what you found in facilities, and of course it goes back to policy implementation. Probably I would like to hear from you what were the facilitators for those facilities that were supported by medical access to achieve a high compliance.
Thank you very much, Grace. Do you have any other question? I think now we can give the mic to Henry. Okay, so if there's no other question, I think we'll give Dr. John an opportunity to respond to that.
Actually, what I meant is that E-systems have a role to play, and they indeed played a role. Now, but it doesn't explain these high results. And these high results are actually more down to aspects that I mentioned, like probably coaching, mentoring, because we've been, personnel have been able to be in other places where they have these e-systems. But again, it doesn't translate to these high level, I mean, like quality of results, 100% reporting, for example. So there is that aspect. I don't know whether it's an aspect to do with the private sector, you know, but, and also I really put down that to for that from the delivery clerk, for example, all through to the project staff, all through within probably medical access, and also the fact that these facilities are also probably private, not-for-profit, because we've been in the public sector, and they do have these systems as well, but they don't translate to these. So that's what I meant, that there is actually value in any funder funding the private, not-for-profit. That's actually, that could summarize my, yeah. Thank you.
Thank you very much, Dr. John. A round of applause for. So our next presenter is Dr. Jesse Luwama, and Dr. Jesse Luwama was our consultant on the economic evaluation of the HSIP project, and we look forward to learning from him. Thank you.
Okay, thank you very much. I appreciate everyone here today. So yes, Jesse, I rarely get called Luwama, so I might be a bit absent-minded. Jesse Kigozi is the common name I tend to use. But yes, thank you for having me here today. So like my colleague said, I want to appreciate Medical Access for the opportunity to be part of this project, and we're happy to contribute in our little way, whichever we can. I want to acknowledge my colleague, Dr. Raymond Opong, in the University of Birmingham. He's an associate professor in health economics. He was with us as well on this project, but he's not been able to join us here. Yes, so just to acknowledge him. Okay, so thank you. So in this presentation, I'm really attaching costs and benefits to most of the things that we've already had, and the recommendations will tend to be in line with what we've already had. For those of us who might not be familiar with economic evaluation, what we do with economic evaluation is to systematically identify, measure, and value inputs and benefits inputs and benefits of alternative courses of actions in most cases. And in this particular in position to exactly do comparisons, it's always very good when economists are involved at the start of a project. That way you're able to sort of ensure that you have information that will help you to do a full economic evaluation. So that's something that would be nice to do. Okay, so I'll quickly move on. We are familiar with those. So I'll go to the economic evaluation questions. So these are the questions that guided what we did. As in most evaluations, we started with the overall cost, and we looked at that primarily by looking at the 4 project outcomes. So that's what was the first thing. The second thing, which is always very informative in any cost evaluation, is to look at where the cost drivers of the project. And that helps the decision makers, the policy makers, the people running the project to focus more on those areas and see if this is to be implemented, what's primarily going to drive the project. If we are to try and look for any cost savings, any innovations, any improvements. Those are some of the areas you can directly look at. We also looked at a question that tried to look at the cost of improving some of the outcomes. And then we also tried to quantify the benefits, potential savings rather that can be identified from the project. Savings obviously can give you an idea of additional funds that could be used to do a bit more work without necessarily adding in funds. And then we looked at the ELMIS that most of us have been talking about and any associated savings that are related to that. So in terms of the methodology, sort of in standard practice, we obviously had a combination of both quantitative data, where you're either reviewing databases, you're reviewing records, and then we had a qualitative component where you have discussions with people, understand the processes, understand the cost components you're looking at, understand the different categories. So we had a bit of that in the methods. I must say costing and economic evaluation projects generally are very, very challenging and complex, and they're only as good as the data you have. And I must commend Medical Access, very, very organized, and they were a joy to work with. So in terms of the data collection, the standard practice and the easiest way to do this is to remember we said we identify, we measure, and we value. So in terms of identification, in addition to the 4 outcomes, we broke these down into functions that were easy for us to attach costs to. So that included obviously the procurement function, the storage function, transportation, management, which is really the coordination at the central level. Health systems strengthening was something which was outside of those 4 functions but sort of feeds into all those functions, and then to get some savings as well. The main output was a total cost, and that's something we modeled by looking at all those components together, and then you're able to get a total cost of that. Like I said, because of the nature of how data was collected and how the setup was of the project, it wasn't possible to conduct a full comparative economic evaluation, but we're still able to do a kind of economic evaluation in the form of a cost effectiveness analysis. And then the cost benefit analysis was more to sort of identify the potential savings that are associated with this project. And one of the cost effectiveness outputs was to look at per unit throughput. And I think that was helpful because it's one of the few things that we can use to compare other projects that have been done outside. The challenge with this obviously is you do not have a threshold that can sort of tell you whether something provides value for money. But the best thing to do is you compare it with other similar projects, and then you can look at how effective this project was. And those are the outcomes that follow on from the analysis. Okay, so the 4 outcomes, the first presentation of the results I'm going to make is related to these 4 outcomes. So we're able to quantify, if we look at outcome 1, most of the costs that we could attach and relate to that were in the primary function. Outcome 2, that was relatively easy to sort of look at where the procurement-related costs were. And then outcome 3, we were able to sort of link that to transport, distribution, and storage as a component. And then outcome 4 is where we're able to link a lot of the training, supervision, e-learning, and generally health system strengthening for ease of reporting. Okay, so the next slide is going to attach some cost to what I've just discussed now. So it's mindful for us now that this is not really a financial cost, this is an economic cost. So there are situations where we have to attach a sort of proportion of the time of the different staff involved in this project. So it's not necessarily a financial cost, it's an economic cost. So if someone, for example, is providing only 20% of their time in activities of this project, that's the portion that would be included in this cost. Okay? But the useful thing is it tells us where most of the resources seem to be going. So outcome 2, we have 41%. wouldn't be necessarily surprising. So outcome 2 would be the procurement. And then the next one is outcome 3, which was about 37%. If you remember outcome 3, that was again related to transport, distribution, storage. So these are major components that are doing activities that are directly relating to the parties, to the patients, or to the people the health system is seeking to serve. So that gives us an idea of where most of the costs have been attributed to. Like I said, it's an economic cost. That's where most of the costs have been attributed to. And if you now want to go and look at a bit of what were the components in that, how can we be a bit more effective in how we use the resources, that's when you now zoom in on something like this. But because of the time and this platform, we are looking more at it on a generic scale. So that was the first thing, by function, by outcome. Then we now looked at it by function. So obviously this is related to what has just been presented. If you look at procurement, again, we have about 42%. Transportation is coming at about 17% of that envelope. And then we have the management function at about 13% of that envelope, health system strengthening, and so on. Storage at about 20%. So that gives us a breakdown that's a bit more specific to the components and functions of the project itself. The next thing we looked at was to try and do a kind of cost effectiveness analysis. Like I said, the traditional way would be to look at the incremental costs associated with different possibilities and options, which is something we do not have in this case. But another approach in such a situation would be to look at the costs that have gone in and then identify an outcome. And in this case, we looked at the throughput. So for about $52 million, we're pushing an output of about $202 million in terms of running this project, coming to a supply chain cost as a percentage of the value of throughput of about 21%. So like I said, the challenge with cost effectiveness analysis is there's no threshold to sort of tell you how excellent what you've got is. But in terms of comparisons, one of the very similar studies that was done in Tanzania had a cost per dollar annual pass-through of about 0.27. So that was about 27%. So this was a bit lower, way better than that. And a few others which I saw still were in the 20s. So in terms of if you compare it to what else has been done, it shows the quality of what has actually gone in here in terms of the money that you've put in and the quantity of products that you're pushing through the system. Then the other challenging one is to sort of identify some potential savings. Now, to do a good job with this required a bit more intensive data analysis and identification. So this is just a snapshot of where some of the savings could be potentially. And this is something that can be done in a bit more detail to be able to identify savings. One of the things we kept hearing was benchmarking. So in relation to ARV drug purchases, for example, in terms of a quantity or a figure, we have here almost about $7 million that were attributed to a potential saving, and that's money that can be used elsewhere. That's in relation to a sample of just the ARV drug purchases and benchmarking. In terms of the write-offs, the project had a target of being under 5% in terms of write-offs during the project duration. And from the data that we have here, it's about 0.38%. It can vary depending on the data you've had and analyzed, but it was still under 1% for sure, which was very good. So in terms of cost saving, what we did was to look at the different targets that exist out there. So we had the 5% from MAUL. We had some targets from WHO, 3%, and then there was a very conservative one of about 1.5%. So we look at that target, that in a situation where you had write-offs of up to that percentage, and then compare that with what actually MAUL achieved, and then if you get the difference in terms of the cost of what attributes to, that's what we were able to model and present here. So it's a model looking at the situation that was expected or that was sort of a standard or benchmark, and then what was actually achieved. If you attach costs to both those situations and then get the gap in that, you're able to sort of have a potential saving as a result of that. Again, that's something that would be very wonderful if one can do in as much detail and looking at data that's available. But those are all, you know, $3 million for a very, very conservative estimate, $8 million, $14 million for the 5% target, and that's all money that can potentially be used to do a bit more work. Okay. Again, we heard so much about the supervision, the mentorship, the coaching, especially the one that took place on an online platform. So I can't quite remember whether it was an innovation that was thought about in advance, probably, or like many of us were also forced by COVID to, you know, a lot of our systems in the university have also adapted for them better as a result of COVID. But this was a serious innovation that obviously leads to a lot of cost savings, because generally the way you do trainings, you bring people in a room, you have to bring them, do a lot of things, but when it moves online, it's actually much more efficient and at the same time does save resources. So for the little data we were able to get and analyze, there were savings that could be realized of up to $181,000 just in adapting the way supervision, mentorship, training, and implementation of all those very important initiatives is carried out on an e-platform as opposed to where it would be carried out in a sort of setting like this. So that's something as well that is quite commendable in terms of providing a bit more efficiency in delivery of services. Then the other one, which were only just to look at a minute section of this, was to look at savings from competitive procurement negotiations. So that's something that kept coming up: smart negotiations, smart packages, benchmarking, up to $8 million, and that was just a snapshot of the data. As you can imagine, the data is way too much. We got just a snapshot of that data, we're able to pick up such a huge figure. I must say, if we were to look at up to more than 20%, it would be even much, much more significant than this. But it shows the importance of smart negotiations and procurement in doing that. All that is part of effectiveness that can then be quantified in terms of potential savings of costs. So that was the outcome that I attempted really to sort of identify. But like I said, it's not as comprehensive because of the nature of the magnitude of the data that's available for us to do that. And it's something that as an individual piece of work, if we were to look into, you can actually definitely have much more significant figures than are reported here. Okay, so those are the numbers. In terms of the key strengths, like most of the things that have been picked up, these are attributed to the costs that have just been presented. The most important thing is that this project led to very, very important advancements in terms of supply chain system efficiency. And in terms of the cost and the outcomes as well, we can clearly see that. This project showed lots of areas where we can actually realize savings. It's sort of the same thing we face in the health financing sector. When you analyze countries that have put in more money and the outputs that have come out, you realize that a lot more has to be spent on the health system efficiency itself before we think of pumping in more money. So this is a very clear case of places where, you know, the system can be made more efficient, less losses, less wastage in the system, without necessarily even adding in more money, makes the whole chain much, much better. Then the procurement practices is something really, really critical. Helps to save funds, helps to save resources that can then be adapted and used for more meaningful and things that contribute to the patient benefits in the country. Then the training and supervision as well, very, very innovative. You know, the consultant who talked about the process evaluation, yes, it might take a bit of people reorienting themselves with looking at a computer and coming onto Zoom or another sort of platform, as opposed to sitting in a room but I think it's something that does definitely provide added benefits, but also is very cost effective as a means of delivering treatment. Something people can also, rather training, people can also, do training at their own leisure, So I think that was a very, very important strength that flows out from the cost data that we've presented and the outcome data. The key thing flowing from that is, yes, the competitive processes and smart negotiations, price benchmarking, those are the keywords, and potential savings is something that we've picked up from this project and will be very helpful for other people going forward. Early on, you can identify places where funds will be saved and then potentially used in other places. Investments in e-learning training would be excellent to make the platforms obviously more user-friendly, more useful to the people that are attending them. Coaching, mentorship, support, supervision. I think, my previous quite a number of years in JCRC, where I was an monitoring and evaluation officer, I remember the support supervision. We did weeks of traveling all over the country to do this type of work. This is really, really a much better experience, having been involved right now as well a lot in teaching online. It does provide a lot of value for money, and we can have quite a lot of savings in that area. Possibly add a bit of hybrid once in a while, not to make it only online. Then, yeah, so I think it's also to explore the different benefits that we are likely to get from ensuring the supply chain has very improved procurement practices. As you saw in both the cost per outcome and the cost of the different functions, procurement was always coming on top in terms of expenditures. And so that's an area where we always need to be looking for improved procurement practices and innovativeness in terms of how we purchase things, which Medical Access, I think, has done quite well and needs to continue doing, and lots of others can learn from that. Okay, so thank you. That's where I'll quickly end with this for this platform. Thank you very much.
Thank you. Thank you very much, Dr. Jesse Chigozi. Just to also mention that Dr. Jesse Chigozi is an associate professor in health economics at the University of Birmingham. So if intellect was a person, we have it here. Yeah, so Dr. Jesse, I have to say that most of my key highlights were actually for you to define most of the words that you kept mentioning. So I think it really shows you that as a country, as supply chain, maybe experts, we really need you to come down and teach us what is health economics and how can we evaluate some of the programs that we do run. So I'll take this opportunity to invite any questions that we may have from the audience for Dr. Jesse, even if it's a definition of a word. Yes, Grace.
Thank you, Dr. Jesse. Mine is a comment. I remember, because somewhere you mentioned whether Mawol started the virtual or e-learning. Maybe they could have learned from COVID, but I remember they had already embraced this technology even before COVID came on board. I don't work with Mawol, but I'd worked closely with them, having worked with CDC. They had already embraced the technology, and they were doing the mentorship via the online programs. So when COVID came on board, of course, they were good to go and run. My other comment is usually in negotiations impact on timeless of procurement. I don't know whether you had, and of course, one of the quality indicators for procurement is the timeliness. I don't know whether you had some time to look at that. When Mawol was doing the negotiations, how did it impact on the timeliness of the procurement process? Thank you.
Thank you very much, Grace. Do we have any other questions? Yes?
Thank you. My name is Henry Subi. I work with the Uganda Catholic Medical Bureau. I don't know what the cutoff for the data that you collected is, but I was interested specifically in looking at the, was it write-offs due to expiries? I know that as the project is winding down and after the transition, maybe you may want to review data on expiries, because currently in most of the facilities that received commodities from Maul then, a lot of these products are sitting expired in these facilities. Of course, some of this is occasioned by the changes in the treatment guidelines. So some of the commodities that were supplied then were not used and they're expired, and you may want to quantify this as well and include it in the analysis. Thank you.
Thank you very much, Henry. I think we'll take those questions for the meantime, and Dr. Jess will respond to those. Thank you.
Okay. Thank you very much, Henry. I think I'll start off with that one. Yes, evaluations are always to the point of when you've actually done the analysis. I think it would be interesting to sort of find out what happened after that. But yeah, putting into consideration the different things we talked about, transitions and all that. Yeah. Okay. Yes, so in terms of the timeliness, I think John might be able to say something on that. But so what was presented here again is more in terms of the practice itself and the advantages that are attached to that. And I imagine my understanding is obviously people like Medical Access who have perfected the art of doing this would have sort of advanced in terms of the timeliness. And other people who are starting on early on can, I think, benefit a lot from the databases they have, the approaches they have, and the way they've done it. But I think the outcome evaluation could say one or two things about the timeliness. Then, yes, I think, please pardon us, we've done this a bit previously, and there's thousands, lots of other projects that we do on a daily basis. So yeah, I'm not surprised that Maul had that in plan already. So I think that's very good to know that they already had the online. They had already caught that vision even before COVID came in. I'm not really surprised because they are quite a visionary company. So yeah, thank you for clarifying that. John, do you have anything to say about the timeliness?
Regarding the issue of timeliness of suppliers, this is something that we did look at. We looked at a couple of, Maul keeps actually files of all their suppliers, and we did review a number of them for, like, if you remember, our colleague in the outcome evaluation mentioned the criteria that Maul uses to classify these suppliers. Timeliness was one of them. Yes, at the time of the evaluation, Maul had a target. They expected 100% supplier compliance, because first of all, because they had these relationships with all these many suppliers. At the time of the evaluation, I think that indicator was scoring about 80. Was it about 80? That was by mid-year 4. And the explanation for why that indicator was at that level was many of the issues were beyond the preserve of the project. But ultimately, there is a rigorous method. You can imagine there was something we picked, for example, again, like we've been around these projects, where Maul assesses ease of communication with the supplier. Can you imagine? Ease of communication. If they find or deem that you don't have, or you're not communicating as they would want, they would again classify you as not somebody probably to work with again. So they had these suppliers that they have through a set criteria. Again, that's what I said. These criteria are there, and luckily for Maul, they've been able to follow them to the letter and have been able to identify reliable suppliers. And I'm sure that by the end, I've not looked at the indicators as of end of closeout. I'm sure probably by that stage they were working towards getting probably 100% supplier compliance. Something that may affect time. Again, we found that they had factored this, they had given it they've given it ample time within their, if you look at those files actually, for whatever follow-on project that is coming, if you look at these files, the way they've distributed the time to do the negotiation, to do the benchmarking, they've spread out this time properly and are able to award in time and probably receive on time. So to answer your question again, like more precisely, we didn't find that negotiations was affecting timeliness of delivery. Thank you.
Thank you very much, Dr. John. So let's give a round of applause to Dr. Jesse. Thank you very much.
We have one more question from Henry.
Thank you. Sorry to disappoint you, Andrew. But in terms of the, I'm interested in understanding the evaluation of the effectiveness of the capacity building approach. Doctor, I don't know if there's a cost effectiveness analysis or, but anyway, my question is really in terms of what it was reviewed against. From my little knowledge, which probably is not that much anyway, is that you probably look at the alternative mechanisms in which we would build capacity. For example, I know in the country we have other options. We have a digital system where health workers evaluate themselves. We have medicines managed supervisors. We have district health teams which also go to the facilities. Ministry of Health itself also goes to support facilities. We have had about the eSPAs app. We have had of medical accesses technical officers. Now, at the end of the day, government is supposed to take up some of these things, but also considering the cost and efficiency. Are you able to give some advice of what the ideal model should be, considering the limited resources?
So thank you very much. That would be a very interesting piece of work to look into, and it obviously was outside the remit of this particular work we did. So yes, economic evaluation is ideally supposed to be a comparative piece of work, and you need to compare like with like when you're doing that. So if you have what Mawul were doing, and maybe you have one of the other systems you've talked about at about the same time and in sort of the same context, you can compare and see what happens with them. So we couldn't do that, obviously, to be able to have a realistic attribution in this particular piece of work. So what we did in terms of identifying the potential savings is sort of similar to what has been done with the benchmarking and price negotiation. So in this case, there's alternative ways that supervision, training, and coaching is actually done. And the wonderful thing is that there's also budgets that can be attributed to that. So you can have a budget that tells you how you would have done support, supervision, coaching, mentoring for that whole year. And then you also have what you actually did, which was do it online and in a different way. So that's what we're able to look at, and then look at the savings that would be gained as a result of doing it the way they actually did it. So we modeled, this is what you call modeling in different ways. So we modeled what you would have done if you went the traditional way and then obtained those costs. And then we now estimated what was actually done using the online coaching and E-related supervision, and then obtain an economic cost for that, and then the gap between those two tells you the savings. So that's the approach that we did. But yes, the one you mentioned would be excellent, but it's something you'd have ideally set in place before the work is done, and then evaluate those different options. So that would be something interesting to look at the different sort of systems that exist, and maybe look at whether there is any secondary related information that has been reported around the benefits attached to them, and then try to model a comparison between them. But that's something we obviously we couldn't do within this particular remit. But thank you very much. It's a very, very interesting way of looking at it as well.
Thank you very much. So around for the HSIP project, who's also representing the CDC country director. She has worked with us on this journey. She has mentored us. We've learned from each other. And today we are privileged that we are celebrating and bidding farewell to the HSIP project. Please join us together to welcome Dr. Christina Mwangi, who will be sharing with us remarks as we bid farewell to the HSIP project.
Good afternoon. Thank you very much for having us here. Let me start by observing protocol. I think I've got a problem. Commissioner, Department of Pharmaceuticals and Natural Medicines, Mr. Maurice Seru. The Executive Director, Medical Access Uganda, Mr. Soedi Muyingo. The Senior Director of Programs of Maul, Rashid. Representative of government entities here present. The representatives of development partners. Implementing partners here present. My US colleagues, all protocols observed. As per the last comment, which was we're bidding farewell, I would like to say we're not bidding farewell. We're continuing a journey together. I am pleased to be with you here today as we share experiences from 12 years of jointly implementing the health supply chain improvement and the procurement and supply chain strengthening projects. The U.S. Centers for Disease Control and Prevention, or CDC, is the United States' premier public health agency and a key PEPFAR implementing agency at the forefront of global HIV efforts, bringing scientific and technical expertise to bear in more than 50 countries and leading the way on a number of critical fronts. Some of you may not know, but CDC has enjoyed close collaboration with Medical Access Uganda Limited since the founding years of the PEPFAR program in 2003, when we partnered to deliver PEPFAR-funded ARVs for the then budding HIV treatment programs. Building on this early success, we signed a 5-year cooperative agreement with Medical Access, Maul, in 2011 to provide procurement and supply chain management services for CDC PEPFAR-funded faith-based and private not-for-profit partners. These services included supply of HIV drugs and TB-related commodities to CDC-supported health facilities, and Maul did not disappoint us. As we worked together, we learned that Maul established incredible relationships with its suppliers, diligently conducting price benchmarking and negotiating for the best prices, helping the project to realize a substantial cost saving of up to $7.49 million US. This enabled us to procure more drugs, enough to treat about 80,000 adult patients on first line for a year, thus supporting the Ugandan government in achieving its ambitious treatment goals and saving more lives. Well done, Maul. As Jonas Salk, an American virologist and medical researcher, said, the reward for work well done is the opportunity to do more. In 2017, CDC awarded Maul a follow-on grant under the Health Systems Improvement Project, HSIP, to ensure an uninterrupted supply of HIV and TB-related commodities and strengthen sustainable supply management practices right from the health facility level. This was premised on the fact that without appropriate training for health personnel in standard treatment guidelines, forecasting and quantification tools, as well as logistics management for health commodities, achieving AIDS-free generation could not be attained. Again, Maul did not disappoint us. They immediately embarked on training health workers to strengthen their capacity in procurement and logistics management for health commodities. They also championed introduction of Ministry of Health ordering tools for antiretroviral medicines for ART and PMTCT, as well as HIV-related laboratory commodities. These have remained critical in ensuring that laboratory supplies, testing kits, and information are effectively passed along the supply chain to the final user, improved health worker motivation, and ultimately the quality of health services being offered to Ugandans. Today marks the culmination of over 20 years of collaboration with Maul, with 12 consecutive years of collaboration under the PSSP and HSIP projects worth $7.6 million in 2011 to a peak of over $60 million per year under the second grant. That's the level of responsibility that Maul was carrying. CDC celebrates this enduring relationship. We have achieved a lot together, enabling many more patients to access these life-saving medicines when and where they need them most. Under our partnership between 2011 and 2022, Maul procured and delivered over $530 million worth of commodities across the country and directly supported delivery of ART to a remarkable 320,000 clients per year. This represents 65% of all PEPFAR clients in the PNFP sector on ART, or 25% of all Ugandans who are on ART, and a significant contribution to CDC's global targets. Thank you. According to a new analysis, CDC and partners, including Maul, and many of you here present, are responsible for the majority of PEPFAR treatment efforts. CDC supports more than 60%, actually 62% of all people with HIV on PEPFAR-supported antiretroviral treatment. So we acknowledge the impact Maul has had on 60% of all those who are on ART in Uganda. Additionally, PEPFAR's efforts have not only dramatically altered the course of the HIV pandemic, but have also strengthened the systems that keep the world safe from other global health threats. In our efforts to improve Uganda's ability to prevent, detect, and respond to public health threats, CDC supported Ministry of Health in the establishment of a strong laboratory system. With Maul handling the procurement and delivery of quality laboratory equipment, we set up a state-of-the-art National Health Laboratory Services Complex in Butabika in 2016. Since then, the country has witnessed improved coordination of laboratory services through the effective National Sample Transport Network and better access to quality laboratory services, including viral load monitoring for patients on ART, early infant diagnosis, quality assurance, and other aspects of laboratory services coordination. Thank you, Maul, for being a reliable partner across all our programs. As we share experiences and pertinent issues affecting the supply chain of HIV/TB programs in Uganda, we acknowledge that there have been challenges such as limited funding in the face of a patient scale-up, unreliable HIV commodity flow within the public systems necessitating frequent buffering requests, and the poor road network thus hindering access by the delivery vans to the sites. I'm sure some of these challenges remain. However, like I said, we continue to work together. As you transition to our sister US agency, USAID, you must do everything possible to get these life-saving medicines and related commodities to those that need them in time and uninterrupted. What you did for us, do for them, because at the end of the day, you do this for all Ugandans. With all evolving world-class research and science in production of superior medicines, if they do not reach those in need, we all labor in vain. USG PEPFAR in January 2020 adopted the Interagency Supply Chain Consolidation Plan for Uganda. USAID was designated as the USG Supply Chain Technical Lead for Procurement, Warehousing, Distribution, and Technical Assistance for the PEPFAR Uganda program. As we close out this cooperative agreement, CDC is indeed happy to note that in addition to the amazing work that has been accomplished, Maul is one of the recipients of the new Local Partner Awards issued by USAID for the procurement of commodities for the PEPFAR Uganda program. In closing, we recognize the excellent partnership CDC and the entire program, PEPFAR program, have had with Medical Access, and commend you for the stellar performance acknowledged by many over the years. What might not be common knowledge to this room is that Maul has been assessed over and over and over again. I have known Maul since, not 2016, it was before 2016. And they have had assessments in terms of their procurement efficiency. They have had assessment about their warehousing. They have had assessments about their distribution capacity. They have had assessment on how well they fulfill the orders that are given to them. In all those instances, Maul was number one amongst all the warehouses in the country. So as we hand you over to USAID, we are handing over a stellar performer. Today, we can happily say that the PSSP project has been a successful effort in improving the lives of many Ugandans, and it's my hope that we learn and build on these successes. Congratulations once again, and thank you for walking this journey with CDC and PEPFAR. We appreciate your contribution and wish you more success in the future. Thank you.
Thank you very much, Dr. Christina. As Medical Access and citizens of Uganda, we convey our gratitude for the work that PEPFAR has done in strengthening the national supply chain systems. Thank you very much. So at this juncture, I would like to invite our Executive Director, Mr. Soedi, who will then invite our guest of honor.
Thank you, and good afternoon, everyone. I think my job is very simple, but before I do that, I would like to appreciate Dr. Christina. Those words means so much for us, and probably I'll say more to that in a few minutes. But it's an honor and privilege to invite our guest of honor, Dr. Maurice Seru, representing the Ministry of Health, to talk to the audience. Thank you, Dr. Maurice.
Thank you, Soet. The country director, CDC in Uganda, representative from Health Development Partners, the board of directors and senior management, Medical Access Uganda Limited, implementing partners, distinguished guests in your various capacities, good afternoon. As you've heard, my name is Seru Morris. I'm the Commissioner, Pharmaceutical Services and Natural Medicine at the Ministry of Health. Ladies and gentlemen, you will agree with me that Uganda has made tremendous progress in the combat against HIV/AIDS since the inception of this epidemic over 20 years ago. Through the hard work and tireless effort of the Ministry of Health, together with our development partners and stakeholders, we have witnessed a 60% decline in new HIV infections and the HIV-related death dropping by half, all within a space of 10 years. Uganda is among the 14 countries to achieve the 90-90 target by the end of 2020. These results can be directly linked to other achievements that include increased access of life-saving ARV medicines, evidenced by an ART coverage of 92%, a viral load suppression rate of 92%, a drop from 94% in 2021. Having hit this milestone, Ministry is now working tirelessly to ensure we achieve the clinical cascade of 95, 95, 95, including strengthening of the supply chain of medicine and diagnostics. Distinguished guests, allow me to draw to your attention to the significance of building an efficient supply chain for the healthcare commodities has played in both our current achievement and how pivotal it is to our future endeavors. Additionally, to the vast investment made by our development partners and stakeholders like Medical Access Uganda Limited in strengthening the same to make it more evident. Ladies and gentlemen, in 2022, the Ministry of Health therefore launched a 10-year National Health Supply Chain Roadmap, whose aim is to ensure the sustainability of all the investment made by the development partners in the health supply chain in Uganda. And when Drake was presenting, he talked of some challenges like internet connectivity, lack of electricity. In this roadmap that has been catered for, we realize as Minister of Health, some of these things are outside our mandate. Therefore, the roadmap, basically it's coordinated at the Office of the Prime Minister. And all the other relevant MDAs are involved. We have ICT, we have public service, we have local government, and their roles in this roadmap are well spelled. And I think next week we're going to have a supply chain week whereby we will be comparing notes how far we've gone since this roadmap was launched. So this roadmap is our strategy to plan, facilitate, and effectively manage the national health supply chain system independent of donor support as Uganda moves toward a self-reliant middle-income country. Again, during the course of the week, I invite you to participate in these activities to see how far we are going and the challenges we're meeting. So far, some of the achieved milestones are instatement of an emergency logistics management system which links facilities, district, Ministry of Health headquarters, national medical stores, utilization of an e-learning platform for capacity building, and the launch of real-time commodity stocks dashboard, among others. This and many more would not have been possible without the unwavering support of the government of Uganda, our partners, PEPFAR, USAID, CDC, Global Fund, CHAI, MSH, local manufacturers, healthcare providers, local communities, and the national warehouse like NMS, JMS, and Medical Access, who are hosts today, and that's the reason we're here. Someone says celebrating their exit, but I'm happy when the CDC tells us we are still together. And that to us is very encouraging. However, allow me also to say that even with this commendable progress and achievements seen over the years, there are a few challenges which are still evident, including regular stockout of medicine and supplies at health facilities, insufficient staffing levels. For instance, 83 of health facilities do not have health supply chain staff, limited domestic financing of essential medicine and health supplies, infrastructure inadequacies at health facilities. For 73 of these facilities do not have access to internet, and 61% are not connected to the national electricity grid. And all these all these are hindrances to our digitalization initiatives outlined in the roadmap. Nonetheless, based on the commitment to the roadmap and wonderful collaboration from the different stakeholders and government agencies, we are certain that these challenges are certainly not insurmountable. The government of Uganda, through the Ministry of Finance, committed to incrementally allocate more financing to the healthcare supply chain. Ministry of Local Government has a commitment to fill the human resource gap we have in the facilities. You know, as the Ministry of Health headquarters, we are responsible for the regional hospitals. But when it comes to the district health office, the mandate to recruit is the district. And I think through the local government ministry, I think they've committed themselves to do that if funds are available, because you may be, the will may be there, but you don't have the what? The resource. The point of additional health work has been prioritized for the next financial year. The Ministry of ICT and National Guidance also indicated that the prioritized list of health facilities will be connected to internet within the next 2 years. The National Drug Authority has also strengthened quality assurance for medicine in country through the registration of the health commodities, licensing of outlets, conducting quality inspection, and most recently increasing their effort on GDP, that's a good dispensing practice, and pharmacovigilance compliance. For us at the Department of Pharmaceutical Services and Natural Medicine, we will continue and even strengthen this important mandate of coordinating all the parties to jointly implement our national drug policy. Our strategic objective as a Ministry of Health in the HIV supply chain include: 1, upgrade and scale up of the e-learning platform to aid with capacity building of healthcare workers. 2, mentorship and monitoring of national and regional referral hospitals into health supply chain management center of excellence under the hub and the spoke model. Scaling up of LMIS at facility level through capacity building to further increase end-to-end visibility of supply chain data. To increase agility of the national health supply chain to absorb shocks from pandemics and other disruption through strong partnership and enhanced capacity building on public health emergencies, availability of stock for emergency medicine and supplies for buffer period, and increase funding to support other critical PHC structure and function. Ladies and gentlemen, when you listen to Rashid's presentation, whatever they are doing are in line or in support of this mandate of our Minister of Health in general, but the department in particular. And I think we would be mentally sick, for lack of a better word, if we don't really pick some of these innovation and learning experiences and implement them in our what? In our activities, or even since most of the activities have gone to JMS and USID, to implore them to make sure these things are what? Are done, because they have been proven to work. And I personally, I commit, as long as I'm still in the department, we'll pursue this thing, we'll pursue this road vigorously. We'd like to once again express our utmost gratitude to our development partners, including PEPFAR, Global Fund, CHAI, for the unwavering support to the sector commodity budget, system strengthening, and support to enable the country to implement the National Pharmaceutical Sector Strategy 225. I'd like to express gratitude to all our stakeholders, including the implementing partners, for your work at the grassroots level. We appreciate and recognize your contribution as a ministry. Finally, I'd like to thank Maul for the commendable job done, right from increasing access of medicine at health facility level and the national level. We also appreciate all the provided technical support in the execution of the National HIV Supply Chain Strategy, the partnership to capacity building and support in all the initiatives that have been undertaken by the department. The gain from this collaboration has been significant to our strategic objective, and this partnership with Maul and other stakeholders is a definite necessity to the achievement of even more milestone to the Minister of Health and the country. I'd like to end by imploring all of us to continue to work, all of you to continue to work with the Department of Pharmacy and Natural Medicine to implement the different strategies so that we can achieve the milestone we've set for the service of our people. Thank you so much for listening to me, and may God bless.
Thank you very much, Commissioner. Pleasant remarks. We do appreciate the collaboration that Medical Access has had with the ministry over the years in implementing both projects under CDC. So thank you very much, and we look forward to that continued collaboration. As we come to the close of our summit, I would like to welcome the Executive Director, once again, of Medical Access, who will give a vote of thanks for the team that is here. Thank you.
Good afternoon again. The guest of honor, Dr. Maurice Seru, Commissioner representing the Ministry of Health, the CDC Country Director, represented by Dr. Christina Mwangi, who also, luckily, doubles as our project officer, distinguished guests, ladies and gentlemen. I would like to thank you for joining us this morning in bidding farewell to the closure of the HSIP project. It has been nearly 20 years, as Dr. Christina mentioned, that we've been working together with CDC in supporting the implementation of the procurement and supply chain of HIV and TB commodities in the private sector in Uganda. First and foremost, I would like to express my heartfelt gratitude to each and every one of you here today. As we came in the morning, it's a little very warming and great to see many familiar faces with whom we have worked over the years. Many of whom are here with us this afternoon. But I also like to recognize just a few names that I've worked with in the past who have been part of this journey. The names may be familiar to some of you who've been here for a while. Jono, who used to be one of the CDC country directors, Tadese, Dr. Steve Wisma, Deborah O'Connor, Dr. Monica Dia. I can go on and on and on, So you remember these names. I would also like to recognize the late Kizra King. We worked, he's one of the POs that we worked with. Maybe I would say probably the longest. May his soul rest in eternal peace. These individuals have been part and parcel of the success of the last 20 years of supporting and making a contribution in attainment of the PEPFAR goals, the 95-95, as well as in the elimination of HIV in Uganda. Over the course of the years, we have witnessed a number of challenges. I'm not going to go into enumerating many. I think Dr. Rashid and other consultants have presented a number of these here this morning. But I'd also like to reflect on a couple of those that have stood out, that are worthy mention. As an organization, in partnership with CDC and PEPFAR, we've been able to create a wealth of knowledge and skilled young talent in Uganda, many of whom still continue to work with us. The chair for this session is one of those products. There are a number of others, like Henry, who has stood out in asking as many questions as we can, is our product of this, and many others working both locally, internationally, with many organizations, USAID, MSH, and the others. We also like to recognize the contribution that this has done to our operations as well, in terms of the infrastructure. I think we are celebrating the theme here, is leveraging technology and partnerships. So we like to recognize also the contribution in terms of the IT infrastructure that CDC through PEPFAR that has invested in our organization and in implementation of this project. I think I would be negligent if I left without appreciating the contribution of our donors and sponsors. I would like to convey again my heartfelt gratitude to the American people through CDC and PEPFAR for the contribution they have done to our organization, to our country, I think we have had an opportunity of a lifetime. You know, I can cite many opportunities. I think the greatest of all is through this generous support. We've been able to make a contribution as a local and indigenous organization in providing life-saving medicines to our own people. I think many of us have been touched in one way or the other. You know, we've lost our dear ones who never had an opportunity for them to test or take these life-saving medicines. But we've had an honor and the opportunity to be able to do that. And forever we shall continue to be grateful and indebted to the American people. We'd also like to recognize significantly the contribution of the Ministry of Health. Thank you again for bringing us to the national level to be part and parcel of the making and strengthening of the national procurement and supply chain system in Uganda. In closing, I would like to express my appreciation to each and every one of you for your contribution to this remarkable project. Your dedication, passion, commitment has made this endeavor truly extraordinary. I am humbled and honored to have had an opportunity to lead such an exceptional team. As we bid farewell to the project, let us do so with a sense of pride and accomplishment. Let us celebrate the successes. Let us cherish the memories that we have created. And let us continue to endeavor to the best of our abilities to tackle the future challenges and make a lasting difference. I would also like, in honor for the contribution from CDC and all your support, also mention that as an organization, we have evolved. Just like Dr. Christina mentioned, we've been able to leverage this partnership and the opportunity to expand our service offerings. And at the moment, we are working globally in Latin America, in Asia, as well as regionally in Africa. And we've only been able to achieve that through the expertise, the support, and the visibility that we have attained as an organization through working on these projects for the last 20 years. I would like to use the opportunity to thank you again for being part of this incredible journey. Thank you. Thank you, our partners. May God bless you. Thank you.
Thank you very much, Soweidi, for those beautiful remarks. I have to say that this is one of the few meetings which has come to an end at the anticipated time. So as Africans, we've achieved a milestone, a great one. So thank you very much. So I'd like to take this opportunity to say that we've come to the close of our meeting and thank everyone of you for taking that time out of your busy schedules to actually come and celebrate with us. I know HSIP we are bidding farewell, but for us it's a celebration, it's an achievement for the work that we've done for the patients to make sure that they get the drugs on time and also build the capacity, the supply chain capacity of the at the national level. So thank you very much once again, and may God bless you. So I think we would like to take some time and take a few photographs so that we don't miss. We need to capture this moment. So I think Claire will give us details of where we'll be taking the photographs from. Thank you very much.
Yes, thank you, Andrew. I think we've been advised by the photographer to just take it from the front there, right next to the banner, so we could just collect there. It will take a short time, and then we'll invite you to join us for lunch. Some coupons are being given out. We shall use these at the dining. Thank you.